Chapter 1. Introduction to Hemolytic Anemia. Hemolytic anemia is a condition where red blood cells are destroyed faster than the body can produce them. This destruction, known as hemolysis, can occur in the bloodstream or within organs such as the spleen. Hemolytic anemia can be either inherited or acquired, and it often leads to a variety of health complications, depending on the underlying cause. To understand hemolytic anemia, it is important to first explore the structure and function of red blood cells, the body's primary vehicle for oxygen transport. Red blood cells, RBCs, are essential for the efficient movement of oxygen from the lungs to tissues throughout the body and the return of carbon dioxide to be exhaled. These cells are disc-shaped and flexible, enabling them to travel through the body's blood vessels without causing blockages. The lifespan of an RBC is about 120 days, and after this period, they are typically broken down by the spleen. However, in individuals with hemolytic anemia, the destruction of red blood cells occurs at an abnormally high rate, reducing the overall number of healthy RBCs in circulation. The immune system is often a major contributor to this destruction. In autoimmune hemolytic anemia, AIHA, the body mistakenly identifies its own red blood cells as foreign and attacks them. This immune response can be triggered by infections, medications, or even other autoimmune disorders. There are also genetic forms of hemolytic anemia, such as sickle cell anemia and thalassemia, which are caused by mutations in the genes responsible for producing hemoglobin, the oxygen-carrying component of RBCs. Additionally, hemolytic anemia can be triggered by external factors like toxins, certain medications, or mechanical damage to the red blood cells. The symptoms of hemolytic anemia can vary, but they typically include fatigue, paleness, shortness of breath, and an increased heart rate. In some cases, patients may experience jaundice, yellowing of the skin or eyes, which results from the buildup of bilirubin, a byproduct of RBC breakdown. Diagnosis involves blood tests that measure levels of hemoglobin, reticulocytes, immature red blood cells, and bilirubin, among other markers. In conclusion, hemolytic anemia is a condition characterized by the premature destruction of red blood cells, leading to various health challenges. Understanding the biological mechanisms behind red blood cell destruction is key to diagnosing and managing this disorder. The next chapters will delve into the different causes, symptoms, diagnostic methods, and treatment options for hemolytic anemia. Understanding hemolysis. Hemolysis refers to the breakdown or destruction of red blood cells, RBCs, before the end of their typical lifespan, which is about 120 days. This process occurs naturally in the body, particularly in the spleen, where aged or damaged red blood cells are broken down. However, when hemolysis occurs at an accelerated rate, it leads to a deficiency in the number of circulating RBCs, resulting in hemolytic anemia. Red blood cells have a critical role in transporting oxygen throughout the body. The destruction of these cells releases hemoglobin, a protein that carries oxygen into the bloodstream. The body must then remove this excess hemoglobin, which is processed in the liver, and converted into bilirubin, a substance that gives bile its characteristic yellow color. This is why one of the hallmark signs of hemolysis is jaundice, or the yellowing of the skin and eyes, due to high bilirubin levels. There are two primary types of hemolysis, intravascular and extravascular. Intravascular hemolysis occurs when red blood cells are destroyed within the blood vessels themselves, releasing hemoglobin directly into the bloodstream. This type of hemolysis can be caused by mechanical stress, toxins, infections, or immune reactions. On the other hand, extravascular hemolysis takes place when red blood cells are removed from circulation and broken down in the spleen or liver. This is a more common process in individuals with certain inherited conditions, such as hereditary spherocytosis or sickle cell disease. Hemolysis can be caused by a variety of factors. In some cases, it is due to an autoimmune reaction, where the immune system mistakenly attacks the body's own RBCs. This type of hemolysis is seen in conditions like autoimmune hemolytic anemia, AIHA. Other causes include infections that damage RBCs, such as malaria, or the presence of abnormal red blood cell shapes, as seen in sickle cell anemia. Certain medications, chemicals, and even mechanical heart valves can also lead to hemolysis by physically damaging red blood cells. The body can compensate for some degree of hemolysis by increasing the production of new red blood cells in the bone marrow. However, if the rate of destruction exceeds the body's ability to replace the lost cells, hemolytic anemia develops, resulting in fatigue, weakness, and other symptoms. Understanding the various causes and mechanisms behind hemolysis is crucial for diagnosing and managing conditions like hemolytic anemia. Types of hemolytic anemia. Hemolytic anemia can be categorized into two main types: inherited and acquired. Each type is associated with different causes and mechanisms of red blood cell destruction. Understanding these distinctions is essential for diagnosing and treating the condition effectively. Inherited hemolytic anemia results from genetic mutations that affect the structure or function of red blood cells. These genetic conditions are passed down from parents to their children and can lead to abnormal red blood cell shapes, defective enzymes, or problems with hemoglobin production. One of the most well-known inherited forms is sickle cell anemia, where mutations in the hemoglobin gene cause red blood cells to take on a rigid, sickle-like shape. These misshapen cells are prone to breaking apart and causing blockages in small blood vessels. Another inherited form is thalassemia, which involves a deficiency in the production of hemoglobin, leading to fragile red blood cells that are more easily destroyed. Hereditary spherocytosis is another example, where red blood cells become spherical and less flexible, making them more susceptible to breakdown in the spleen. Acquired hemolytic anemia, on the other hand, develops due to factors that are not inherited. This form of hemolytic anemia is typically caused by external conditions or diseases that damage red blood cells. Autoimmune hemolytic anemia, AIHA, is one of the most common acquired types. In AIHA, the immune system mistakenly targets and destroys its own red blood cells. This condition can be triggered by infections, certain medications, or other autoimmune disorders. Another acquired form is microangiopathic hemolytic anemia, MAHA, which occurs when small blood vessels become damaged, leading to the destruction of red blood cells as they pass through. This can be seen in conditions like thrombotic thrombocytopenic purpura, TTP, or hemolytic uremic syndrome, HUS. Other causes of acquired hemolytic anemia include mechanical stress, such as that caused by artificial heart valves, and infections like malaria, which directly infect red blood cells. Additionally, certain chemicals, toxins, or drugs can also induce hemolysis by damaging the red blood cells or altering their normal function. Each type of hemolytic anemia presents unique challenges in terms of diagnosis and treatment. Inherited forms are often diagnosed early in life through genetic testing, while acquired hemolytic anemia may be linked to specific triggers or underlying health conditions. Treatment options vary depending on the type, but may include medications, blood transfusions, or in some cases surgery. Understanding the specific type of hemolytic anemia is crucial for effective management and improving the patient's quality of life. Overview of the immune system's role. The immune system plays a critical role in defending the body against infections, toxins, and other harmful substances. It is made up of a complex network of cells, tissues, and organs that work together to recognize and eliminate pathogens. However, in certain conditions, the immune system can mistakenly target the body's own cells, leading to autoimmune disorders such as autoimmune hemolytic anemia, AIHA, where the immune system attacks healthy red blood cells. In a healthy immune system, immune cells known as lymphocytes, including T cells and B cells, recognize foreign invaders such as bacteria, viruses, and fungi. These cells are designed to differentiate between self and non-self, ensuring that only harmful entities are targeted for destruction. When the immune system detects an infection, it triggers an inflammatory response to neutralize and remove the pathogen. The body also produces antibodies, proteins that can specifically bind to and neutralize harmful substances. However, in autoimmune hemolytic anemia, the immune system loses this ability to distinguish between self and non-self. The body's immune cells mistakenly identify red blood cells as foreign invaders and begin attacking them. This is typically mediated by antibodies, which are proteins produced by B cells. These antibodies bind to the surface of red blood cells, marking them for destruction. Once marked, the immune system's macrophages, primarily located in the spleen, consume and break down the red blood cells. This process results in an accelerated rate of red blood cell destruction, leading to anemia. In AIHA, the immune system's attack on red blood cells can be triggered by various factors, including infections, medications, or other underlying autoimmune diseases. The destruction of red blood cells can occur either inside the blood vessels, intravascular hemolysis, or outside the bloodstream, typically in the spleen, extravascular hemolysis. The role of the immune system in hemolytic anemia is complex, as it involves both the production of antibodies that target red blood cells and the body's defense mechanisms that normally clear these antibodies. Managing autoimmune hemolytic anemia often involves suppressing the immune response, using treatments such as corticosteroids or immunosuppressive drugs to reduce the destruction of red blood cells. Understanding the immune system's role in hemolysis is essential for developing targeted therapies and improving outcomes for individuals with autoimmune hemolytic anemia. Chapter 2: The Biology of Red Blood Cells. Red blood cells, RBCs, or erythrocytes, are vital components of the circulatory system, responsible for transporting oxygen from the lungs to tissues throughout the body and returning carbon dioxide to be exhaled. The biology of red blood cells is crucial to understanding how hemolytic anemia develops, as abnormalities in these cells can lead to their premature destruction. The structure of red blood cells is uniquely suited to their function. They are biconcave discs, which increases their surface area and allows for efficient gas exchange. This flexible donut-like shape also helps RBCs navigate through narrow blood vessels without clogging the circulatory system. Additionally, the absence of a nucleus in mature red blood cells maximizes the space available for hemoglobin, the protein responsible for binding oxygen. Hemoglobin makes up about a third of the cell's total weight, and its ability to bind oxygen is vital for efficient respiration. The lifespan of a red blood cell is typically around 120 days. During this time, the cell constantly circulates through the body, picking up oxygen in the lungs and delivering it to tissues and organs. As red blood cells age, their membrane becomes less flexible, making them more prone to breaking apart, particularly in the spleen, where old cells are filtered and removed from circulation. The breakdown of RBCs releases hemoglobin, which is then broken down into heme and globin. The heme is further processed into bilirubin, a substance that is excreted through bile, while the globin is recycled into new proteins. The production of red blood cells occurs in the bone marrow, a spongy tissue located inside certain bones. This process, known as erythropoiesis, is stimulated by erythropoietin, a hormone primarily produced by the kidneys in response to low oxygen levels in the blood. New RBCs are initially released into the bloodstream as reticulocytes, which mature into fully functional red blood cells within a day or two. In hemolytic anemia, red blood cells are destroyed at a faster rate than they can be replaced. This can be caused by various factors, including defects in the structure of the RBCs, problems with hemoglobin production, or damage caused by immune responses, infections, or toxins. Understanding the biology of red blood cells helps to explain why their premature destruction leads to symptoms such as fatigue, pallor, and shortness of breath, as the body struggles to maintain adequate oxygen levels. Structure and function of red blood cells. Red blood cells, RBCs, are uniquely designed to fulfill their essential role in the body, transporting oxygen from the lungs to tissues and organs, and carrying carbon dioxide back to the lungs for exhalation. The structure of red blood cells is intricately adapted to these tasks, allowing them to circulate efficiently and perform their functions effectively. One of the most distinguishing features of red blood cells is their biconcave disc shape. This shape increases the surface area to volume ratio, facilitating the efficient exchange of gases, oxygen, and carbon dioxide across the cell membrane. The biconcave design also contributes to the flexibility of the cell, enabling it to squeeze through even the smallest blood vessels or capillaries without obstructing the flow of blood. This flexibility is crucial, as RBCs encounter narrow vessels where the ability to deform and return to their original shape ensures smooth circulation. Unlike most cells in the body, mature red blood cells do not contain a nucleus. The lack of a nucleus allows for more space to store hemoglobin, the protein responsible for oxygen transport. Hemoglobin binds to oxygen molecules in the lungs and releases them in tissues where oxygen levels are low. A single RBC can contain millions of hemoglobin molecules, allowing it to carry a substantial amount of oxygen. Additionally, the lack of a nucleus contributes to the RBC's streamlined structure, making it more efficient at navigating through blood vessels. Red blood cells also contain enzymes that help maintain the cell's shape and integrity. The cytoskeleton, a network of proteins within the RBC, helps preserve its biconcave shape and provides flexibility during circulation. As the RBC ages, this cytoskeletal network weakens, making the cell more prone to damage, particularly in the spleen, where older RBCs are filtered out of circulation. The lifespan of a red blood cell is about 120 days, after which it is removed from circulation and broken down in the spleen. The heme component of hemoglobin is converted into bilirubin, a substance excreted in bile, while the globin part is broken down into amino acids and reused by the body. The structure of red blood cells is finely tuned to support their primary function, efficient gas exchange. Any alterations to the cell's shape, membrane, or hemoglobin content can compromise this function, leading to various types of anemia or other blood disorders. Understanding the structure and function of red blood cells is crucial in identifying the causes of hemolytic anemia and developing appropriate treatments. Lifespan of red blood cells. The lifespan of red blood cells, RBCs, is typically around 120 days. This finite lifespan is a crucial aspect of their function, as it ensures that only healthy and fully functional RBCs are circulating in the bloodstream. As RBCs age, their ability to carry oxygen efficiently diminishes, and their structural integrity weakens, making them more prone to breakdown and removal from circulation. Red blood cells are continuously produced in the bone marrow, where precursor cells, known as erythroblasts, mature into fully functional RBCs. Once released into the bloodstream, these cells begin their journey through the circulatory system, carrying oxygen from the lungs to the tissues and organs. The biconcave shape of RBCs allows them to squeeze through narrow capillaries, ensuring that oxygen is delivered efficiently throughout the body. Over time, as RBCs circulate, their cell membranes become less flexible and their components start to degrade. This gradual deterioration is mainly due to the constant stress of traveling through the blood vessels and the natural wear and tear of the cell. The RBCs lose their ability to maintain optimal function, which signals that they are nearing the end of their lifespan. The primary organ responsible for removing aged or damaged RBCs is the spleen. Here, macrophages, a type of immune cell, recognize and engulf the aging red blood cells. This process is known as extravascular hemolysis. During this process, the hemoglobin from the RBCs is broken down into heme and globin. The heme is further processed into bilirubin, which is excreted in bile, while the globin is recycled into new proteins. Although the average lifespan of a red blood cell is 120 days, this can vary slightly depending on various factors, such as the individual's health, or specific conditions like hemolytic anemia. In hemolytic anemia, red blood cells may be destroyed prematurely, either due to immune system issues, infections, or structural abnormalities in the cells themselves. This leads to a reduced lifespan of RBCs and an insufficient number of healthy cells circulating in the body, causing symptoms like fatigue and weakness. Understanding the lifespan of red blood cells is essential for recognizing the dynamics of red blood cell turnover and the impact of accelerated RBC destruction, particularly in conditions like hemolytic anemia. Causes of red blood cell destruction. Red blood cell RBC destruction or hemolysis occurs when RBCs are broken down prematurely, leading to an insufficient number of functional red blood cells in circulation. This can result from a variety of causes, ranging from inherited disorders to external factors such as infections or autoimmune responses. Understanding these causes is crucial for diagnosing and managing conditions like hemolytic anemia. One of the primary causes of RBC destruction is inherited genetic disorders that affect the structure or function of the red blood cells. For example, in sickle cell anemia, mutations in the hemoglobin gene cause red blood cells to become rigid and sickle-shaped. These misshapen cells are more prone to breaking apart and can cause blockages in small blood vessels, leading to reduced blood flow and further damage. Similarly, hereditary spherocytosis is a genetic disorder where RBCs become spherical instead of the typical biconcave shape, making them more fragile and prone to rupture in the spleen. Autoimmune reactions also play a significant role in RBC destruction. In autoimmune hemolytic anemia, AIHA, the body's immune system mistakenly identifies its own red blood cells as foreign invaders and produces antibodies that target and destroy them. This can be triggered by infections, certain medications, or other underlying autoimmune conditions. The destruction of RBCs in AIHA can occur either within the bloodstream, intravascular hemolysis, or in the spleen, extravascular hemolysis. Infections can also contribute to RBC destruction. For example, malaria caused by the Plasmodium parasite directly infects red blood cells and leads to their rupture. The parasite invades the RBCs, multiplying inside them, and when the cells burst, the parasites are released into the bloodstream, contributing to anemia and other complications. Similarly, certain bacterial infections can produce toxins that damage red blood cells, resulting in hemolysis. Other causes of RBC destruction include mechanical damage, such as that caused by artificial heart valves, or certain types of blood vessels that cause excessive shearing of the cells. Toxins, drugs, and chemicals can also lead to hemolysis by damaging the red blood cell membrane or interfering with its function. For instance, certain medications like penicillin can trigger an immune response that targets red blood cells, while chemicals like snake venom can directly break down RBCs. Understanding the various causes of red blood cell destruction is essential for diagnosing and treating conditions like hemolytic anemia. Identifying the underlying cause allows for targeted therapies that can help manage the symptoms and improve patient outcomes. Chapter 3: Causes of Hemolytic Anemia. Hemolytic anemia occurs when red blood cells are destroyed faster than the body can produce new ones, leading to a reduced number of RBCs in circulation. This condition can be caused by a wide range of factors, which can either be intrinsic, originating from within the red blood cells, or extrinsic, resulting from external forces or conditions. Understanding these causes is key to diagnosing and managing hemolytic anemia effectively. One of the primary causes of hemolytic anemia is inherited genetic disorders. These conditions typically result from mutations in the genes responsible for producing red blood cell components, making the cells more vulnerable to destruction. Sickle cell anemia, for example, is caused by a mutation in the hemoglobin gene, which leads to the formation of abnormally shaped red blood cells. These sickle-shaped cells can block blood flow and are more easily destroyed. Another inherited condition is thalassemia, where the production of hemoglobin is impaired, causing fragile red blood cells that break apart more easily. Another major cause of hemolytic anemia is autoimmune hemolytic anemia, AIHA, a condition in which the body's immune system mistakenly attacks its own red blood cells. In AIHA, the immune system produces antibodies that target red blood cells, leading to their destruction. This can occur through a variety of triggers, such as infections, certain medications, or other autoimmune diseases. The two main types of AIHA are warm autoimmune hemolytic anemia, where antibodies attack red blood cells at normal body temperature, and cold agglutinin disease, where antibodies are active at lower temperatures. Acquired hemolytic anemia can also be caused by infections. For instance, malaria caused by the Plasmodium parasite directly infects and destroys red blood cells, leading to hemolytic anemia. Similarly, certain bacterial infections can release toxins that damage red blood cells, triggering hemolysis. Additionally, Mechanical damage from artificial heart valves or other medical devices can shear red blood cells, causing them to break apart prematurely. Toxins and drugs can also contribute to hemolytic anemia. Some medications, such as penicillin or certain chemotherapy drugs, can trigger immune reactions that destroy red blood cells. Toxins from snake venom or chemicals like lead can directly damage red blood cells or interfere with their function, causing hemolysis. Overall, the causes of hemolytic anemia are diverse, ranging from inherited genetic disorders to external factors like infections, toxins, and medications. Identifying the specific cause is essential for developing an effective treatment plan to manage the condition and improve patient outcomes. Autoimmune hemolytic anemia. Autoimmune hemolytic anemia, AIHA, is a condition in which the body's immune system mistakenly targets and destroys its own red blood cells, leading to a shortage of these essential cells in circulation. This autoimmune response results in hemolysis, or the premature breakdown of red blood cells, which can cause a variety of symptoms, including fatigue, pallor, and shortness of breath. AIHA can be either a primary condition or secondary to other underlying health issues, such as infections, cancers, or other autoimmune disorders. The immune system is designed to recognize and attack foreign invaders, such as bacteria and viruses, while leaving the body's own cells unharmed. In AIHA, however, the immune system fails to distinguish between self and non-self, producing antibodies that target red blood cells. These antibodies can bind to the surface of RBCs, marking them for destruction by immune cells, primarily macrophages, in the spleen and liver. This process leads to the accelerated breakdown of red blood cells, resulting in anemia. There are two main types of AIHA: warm autoimmune hemolytic anemia, WAIHA, and cold agglutinin disease, CAD. WAIHA is the more common form and occurs when antibodies, typically of the IgG type, target red blood cells at normal body temperature. These antibodies cause RBCs to be removed by the spleen, leading to extravascular hemolysis. In contrast, CAD is characterized by the presence of antibodies that are active at lower temperatures, usually below 30 degrees Celsius. These antibodies cause red blood cells to clump together and break apart in peripheral areas of the body, such as the fingers and toes, which are more exposed to cold. The causes of AIHA can vary. In primary AIHA, no underlying condition is identified, and the disorder occurs on its own. Secondary AIHA, however, is associated with other diseases, including systemic lupus erythematosus, SLE, lymphoma, or certain viral infections like Epstein-Barr virus. Certain medications, such as penicillin and some chemotherapy drugs, can also trigger AIHA by modifying red blood cells in a way that makes them appear foreign to the immune system. Treatment for AIHA typically involves suppressing the immune response to reduce the production of antibodies that target red blood cells. Common treatments include corticosteroids, immunosuppressive drugs, and in some cases blood transfusions. In more severe cases, splenectomy, removal of the spleen, may be considered, as the spleen is the primary site of RBC destruction in AIHA. Overall, autoimmune hemolytic anemia is a serious condition that requires careful diagnosis and management. Understanding the mechanisms and triggers behind AIHA is crucial for developing effective treatments and improving patient outcomes. Inherited hemolytic anemia. Inherited hemolytic anemia refers to a group of genetic disorders that affect the structure or function of red blood cells, leading to their premature destruction. These inherited conditions are passed down from parents to children and can result in chronic anemia, where the body's red blood cell count is insufficient to meet its oxygen needs. The underlying genetic mutations cause abnormalities in red blood cells, making them more susceptible to breaking down at an accelerated rate. One of the most common inherited forms of hemolytic anemia is sickle cell disease. This condition is caused by a mutation in the hemoglobin gene, which leads to the production of abnormal hemoglobin, known as hemoglobin S. Under low oxygen conditions, red blood cells containing hemoglobin S become rigid and form a crescent or sickle shape. These sickled cells are less flexible and more prone to breaking apart, resulting in hemolysis. Sickle cells also tend to clump together, blocking blood flow in small blood vessels, which can cause pain and organ damage. Another well-known inherited hemolytic anemia is thalassemia, a disorder that affects hemoglobin production. In thalassemia, there is a deficiency in either the alpha or beta globin chains of hemoglobin, leading to an imbalance in hemoglobin production and the formation of fragile red blood cells that are easily destroyed. There are two main types of thalassemia, alpha thalassemia and beta thalassemia, which vary in severity. Individuals with severe forms of thalassemia may require regular blood transfusions to manage their anemia. Hereditary spherocytosis is another inherited condition that causes hemolytic anemia. In this disorder, mutations affect the proteins that maintain the shape and flexibility of red blood cells. As a result, red blood cells become spherical rather than the typical biconcave shape, making them more rigid and prone to rupture when passing through small blood vessels, particularly in the spleen. This leads to increased destruction of red blood cells, causing anemia. G6PD deficiency is a genetic disorder that affects an enzyme responsible for protecting red blood cells from oxidative damage. In individuals with G6PD deficiency, certain triggers, such as infections or specific medications, can cause red blood cells to break down prematurely, leading to hemolytic anemia. The treatment of inherited hemolytic anemia depends on the specific condition and its severity. In some cases, regular blood transfusions or medications like folic acid may be used to support red blood cell production. In more severe cases, treatments like bone marrow transplants or gene therapy may offer potential solutions. Early diagnosis and ongoing management are key to improving the quality of life for individuals with inherited hemolytic anemia. Acquired hemolytic anemia. Acquired hemolytic anemia is a condition in which red blood cells are destroyed prematurely due to factors or conditions that are not genetically inherited. Unlike inherited forms of hemolytic anemia, acquired hemolytic anemia develops as a result of external factors or underlying diseases that cause the body's immune system or other mechanisms to attack and destroy healthy red blood cells. This destruction leads to a reduced number of RBCs circulating in the bloodstream, causing symptoms like fatigue, pallor, and shortness of breath. One of the primary causes of acquired hemolytic anemia is autoimmune hemolytic anemia, AIHA. In AIHA, the immune system mistakenly identifies the body's own red blood cells as foreign and produces antibodies that target and destroy them. This condition can be triggered by infections, certain medications, or other autoimmune diseases. AIHA can be further classified into two main types: warm autoimmune hemolytic anemia, WAIHA, and cold agglutinin disease, CAD. In WAIHA, antibodies attack red blood cells at normal body temperature, leading to their destruction primarily in the spleen. In CAD, the antibodies are active at lower temperatures and cause red blood cells to clump together and break apart in cooler parts of the body. Infections are another common cause of acquired hemolytic anemia. For example, the malaria parasite infects red blood cells, causing them to rupture as the parasite multiplies inside them. Similarly, certain bacterial infections can release toxins that directly damage red blood cells, leading to their premature destruction. In some cases, the body's response to these infections also triggers an immune-mediated breakdown of RBCs. Certain medications and toxins can also induce acquired hemolytic anemia. Drugs like penicillin and some chemotherapy agents can trigger an immune response that causes red blood cells to be destroyed. Toxins from snake venom or chemical substances like lead can damage the red blood cell membrane, leading to hemolysis. Mechanical causes of acquired hemolytic anemia include the physical destruction of red blood cells. For instance, artificial heart valves or other medical devices that come into contact with blood can shear red blood cells as they pass through, leading to hemolysis. Treatment for acquired hemolytic anemia generally focuses on addressing the underlying cause. For autoimmune forms, immunosuppressive drugs, corticosteroids, or in some cases, splenectomy, removal of the spleen, may be recommended to reduce the destruction of red blood cells. Infections and toxin-related hemolysis are treated by addressing the infection or removing the toxin. Managing acquired hemolytic anemia requires a comprehensive approach to ensure that the underlying cause is identified and effectively treated. Chapter 4: Symptoms and Diagnosis. Hemolytic anemia occurs when red blood cells are destroyed more rapidly than they can be replaced, leading to a reduced number of healthy red blood cells circulating in the bloodstream. The symptoms and diagnosis of this condition depend on the severity of anemia, the underlying cause, and the speed at which red blood cells are destroyed. The most common symptoms of hemolytic anemia are related to the body's inability to carry adequate oxygen. Fatigue and weakness are the most prominent, as the body struggles to maintain sufficient oxygen levels in the tissues. People with hemolytic anemia may also experience shortness of breath, particularly during physical exertion, as the body attempts to compensate for the lack of oxygen-carrying red blood cells. Pallor or a pale complexion is another common symptom due to reduced red blood cell count. In more severe cases, individuals may develop jaundice, which is a yellowing of the skin and eyes. This occurs because the breakdown of red blood cells releases bilirubin, a substance created when hemoglobin is broken down. Excess bilirubin can accumulate in the body, leading to jaundice. Additionally, dark-colored urine may occur due to the presence of hemoglobin or its byproducts, indicating that red blood cells are being destroyed in the bloodstream. The diagnosis of hemolytic anemia begins with a thorough medical history and physical examination. A doctor will typically inquire about any symptoms, medical conditions, medications, or family history that could point to an underlying cause of the anemia. The physical exam may reveal signs of jaundice or an enlarged spleen, which is common in some forms of hemolytic anemia. Blood tests are essential for confirming the diagnosis. A complete blood count (CBC) is typically the first step, revealing a reduced red blood cell count and low hemoglobin levels. A peripheral blood smear may also be performed to examine the shape and appearance of the red blood cells, which can provide valuable information about the cause of hemolysis. For instance, sickle-shaped cells may indicate sickle cell anemia, while spherical cells might suggest hereditary spherocytosis. Further diagnostic tests may include measuring bilirubin levels to check for jaundice and conducting a reticulocyte count, which measures the number of immature red blood cells being produced by the bone marrow. Additional specialized tests, such as the Coombs test, can help determine if the hemolysis is immune-mediated, while enzyme assays can identify conditions like G6PD deficiency. Ultimately, diagnosing hemolytic anemia involves a combination of clinical evaluation, laboratory tests, and sometimes genetic testing to determine the exact cause. Early diagnosis is crucial for managing the condition and preventing complications. Common symptoms of hemolytic anemia. Hemolytic anemia occurs when red blood cells are destroyed at a faster rate than they can be produced, leading to a shortage of healthy red blood cells in the bloodstream. As a result, individuals with this condition may experience a variety of symptoms, which can range from mild to severe, depending on the degree of anemia and the underlying cause. The most common symptom of hemolytic anemia is fatigue. Since red blood cells are responsible for transporting oxygen throughout the body, a decrease in their number leads to reduced oxygen supply to tissues and organs. This lack of oxygen can make even simple activities feel exhausting, and individuals often report feeling unusually tired or weak. Another common symptom is pallor, or paleness of the skin, especially in the face or the inner lining of the eyes. This occurs because of the reduced number of red blood cells, which gives the skin a less reddish hue. In addition to pallor, individuals with hemolytic anemia may experience dizziness or lightheadedness, particularly when standing up quickly, as a result of the reduced oxygen supply to the brain. Jaundice, a yellowing of the skin and the whites of the eyes, is another hallmark symptom of hemolytic anemia. It occurs because the destruction of red blood cells releases excess bilirubin, a byproduct of hemoglobin breakdown. The liver processes bilirubin, but when there is too much of it, it accumulates in the skin and eyes, resulting in a yellowish tint. Shortness of breath is also common, especially with physical exertion. Since the body has fewer red blood cells to carry oxygen, the individual's breathing rate increases to compensate, making simple tasks such as climbing stairs or walking longer distances more challenging. Additionally, dark-colored urine may occur, which is another result of the breakdown of red blood cells. When hemoglobin from destroyed red blood cells is released into the bloodstream, it can be filtered by the kidneys and excreted in the urine, causing it to appear darker than usual. In more severe cases, individuals may experience an increased heart rate or chest pain, particularly during physical activity, as the body works harder to supply oxygen to vital organs. These symptoms indicate that the body is struggling to cope with the effects of hemolytic anemia. The severity and combination of symptoms can vary based on the underlying cause and the extent of the anemia. Prompt diagnosis and treatment are essential to manage the condition and alleviate symptoms. Diagnostic tests for hemolytic anemia. Diagnosing hemolytic anemia involves a series of tests to confirm the condition, determine its severity, and identify the underlying cause. The process typically begins with a comprehensive medical history and physical examination, followed by a variety of laboratory tests that provide critical information about the red blood cells and the body's overall health. The first step in diagnosing hemolytic anemia is a complete blood count, CBC. This test measures the number of red blood cells, hemoglobin levels, and other components of the blood. In hemolytic anemia, the CBC typically shows a reduced red blood cell count and low hemoglobin levels, indicating the presence of anemia. Additionally, the reticulocyte count, which measures the number of immature red blood cells produced by the bone marrow, is often elevated in cases of hemolytic anemia, as the body attempts to compensate for the rapid destruction of mature red blood cells. A peripheral blood smear is another key diagnostic tool. This test involves examining a sample of blood under a microscope to assess the shape, size, and appearance of red blood cells. The smear can provide valuable clues about the cause of the anemia. For example, sickle-shaped cells suggest sickle cell anemia, while spherical cells may point to hereditary spherocytosis. The presence of fragmented red blood cells, known as schistocytes, can indicate mechanical hemolysis or the effect of artificial heart valves. The Coombs test or antiglobulin test is used to determine whether the hemolysis is immune-mediated. This test detects antibodies or complement proteins attached to the surface of red blood cells. A positive result indicates autoimmune hemolytic anemia, AIHA, where the immune system mistakenly attacks its own red blood cells. The test can be further categorized into direct and indirect Coombs tests, with the direct test being more commonly used to diagnose AIHA. Bilirubin levels are also measured to assess the degree of red blood cell breakdown. When red blood cells are destroyed, they release hemoglobin, which is broken down into bilirubin. Elevated bilirubin levels can lead to jaundice and indicate ongoing hemolysis. Additional tests may include enzyme assays such as a glucose 6-phosphate dehydrogenase (G6PD) test to diagnose conditions like G6PD deficiency. Genetic testing may be used in cases of suspected inherited hemolytic anemias, such as sickle cell disease or thalassemia. By combining these diagnostic tests, healthcare providers can accurately diagnose hemolytic anemia, identify its underlying cause, and determine the most appropriate treatment plan. Challenges in diagnosing hemolytic anemia. Diagnosing hemolytic anemia can be complex due to the wide range of symptoms it shares with other conditions and the variety of causes that can lead to red blood cell destruction. Hemolytic anemia can develop rapidly, and its symptoms may be subtle or mistaken for other health issues, making early detection challenging. Several factors contribute to the difficulty in diagnosing this condition. One major challenge is that the symptoms of hemolytic anemia, such as fatigue, pallor, jaundice, and shortness of breath, are common to many other forms of anemia or even general health conditions. These nonspecific symptoms can lead to misdiagnosis or delay in seeking proper testing. For example, fatigue and pallor are not unique to hemolytic anemia, and are often seen in iron deficiency anemia or chronic disease anemia. Without further testing, it may be hard to differentiate between these conditions. Additionally, hemolytic anemia can be caused by a wide range of underlying conditions, including autoimmune diseases, infections, genetic disorders, medications, and toxins. This makes pinpointing the exact cause of hemolysis difficult. Some forms, such as autoimmune hemolytic anemia, may develop over time with no clear trigger, while others may be secondary to other health issues like infections or cancers. In these cases, a thorough medical history is essential to help identify any potential underlying causes. Another challenge lies in the variability of the condition itself. Hemolysis can occur at different rates, and the severity of symptoms can vary widely among individuals, even with the same underlying cause. Some people may experience only mild symptoms, while others may have severe, life-threatening complications. The presence of other health conditions or complications can further complicate the diagnosis, as physicians must consider a range of potential diagnoses before arriving at the correct one. Additionally, diagnostic tests for hemolytic anemia can be complex and may require multiple stages of evaluation. A complete blood count, CBC, reticulocyte count, and peripheral blood smear are essential, but they may not always provide definitive answers without further specialized testing. Tests like the Coombs test, which detects immune-mediated hemolysis, or genetic testing for inherited conditions, may not always be performed initially and can delay diagnosis. Finally, hemolytic anemia can sometimes be masked by compensatory mechanisms in the body. For instance, the bone marrow may increase red blood cell production in response to hemolysis, making the anemia less apparent in early stages. This can further complicate diagnosis, as the body's adaptive responses may initially obscure the severity of the condition. Overall, diagnosing hemolytic anemia requires a combination of clinical suspicion, detailed patient history, and a variety of diagnostic tests. Early recognition is crucial for effective treatment, but the complexity of the condition makes it challenging to diagnose in a timely manner. Chapter 5: Treatment Options. The treatment for hemolytic anemia depends on the underlying cause of red blood cell destruction, the severity of the condition, and the overall health of the individual. While there is no one-size-fits-all approach, several treatment options are available to manage the condition and alleviate symptoms. The primary goals of treatment are to stop the destruction of red blood cells, correct anemia, and address any underlying factors contributing to hemolysis. For autoimmune hemolytic anemia, AIHA, the first line of treatment often involves corticosteroids, such as prednisone, which suppress the immune system and reduce the production of antibodies that target red blood cells. Steroids can help decrease the immune response, improving red blood cell survival. In some cases, other immunosuppressive drugs, such as azathioprine or cyclophosphamide, may be used if steroids are ineffective or if long-term treatment is necessary. If the anemia is severe or if the spleen is involved in destroying red blood cells, a splenectomy, surgical removal of the spleen, may be recommended. The spleen is a major site of red blood cell destruction, and removing it can improve red blood cell survival in some patients with AIHA. However, this option is typically considered only when other treatments have failed. In cases of hemolytic anemia caused by infections, such as malaria, the underlying infection must be treated to stop the hemolysis. Antimalarial drugs, for example, can be used to target the parasite responsible for destroying red blood cells. Similarly, antibiotics or antiviral medications may be necessary to treat bacterial or viral infections that contribute to hemolysis. For individuals with inherited forms of hemolytic anemia, such as sickle cell disease or thalassemia, the treatment strategy is different. In sickle cell disease, pain management, blood transfusions, and hydroxyurea, a drug that helps increase the production of fetal hemoglobin, are common approaches. Bone marrow transplants may be a potential curative treatment for some patients, though this option is typically reserved for severe cases. Thalassemia patients may require regular blood transfusions to maintain adequate red blood cell levels. Iron chelation therapy is often necessary to prevent iron overload, a common complication from frequent transfusions. In some cases, bone marrow or stem cell transplants may be considered. For hemolytic anemias caused by enzyme deficiencies, such as glucose 6-phosphate dehydrogenase (G6PD) deficiency, treatment focuses on avoiding triggers that could lead to hemolysis, such as certain medications or infections. In some instances, supportive care, including blood transfusions, may be necessary if the anemia becomes severe. Overall, the treatment of hemolytic anemia requires a personalized approach, taking into account the specific cause, severity of symptoms, and patient factors. Early intervention and appropriate management are crucial to improving outcomes and preventing complications. Pharmacological treatments. Pharmacological treatments for hemolytic anemia are aimed at addressing the underlying cause of red blood cell destruction, alleviating symptoms, and preventing further complications. The specific treatment plan depends on the type of hemolytic anemia and the severity of the condition, with medications being a cornerstone in managing many forms of the disease. For autoimmune hemolytic anemia, AIHA, corticosteroids are commonly the first line of treatment. Drugs like prednisone are used to suppress the immune system and reduce the production of antibodies that attack red blood cells. Corticosteroids can be effective in controlling the immune response, improving red blood cell survival, and alleviating symptoms. However, long-term use of corticosteroids can lead to significant side effects such as weight gain, osteoporosis, and increased susceptibility to infections, which may require careful management. If corticosteroids are not effective, or if side effects become problematic, other immunosuppressive drugs may be used. Medications like azathioprine, cyclophosphamide, or rituximab are sometimes prescribed to further suppress the immune system and reduce hemolysis. Rituximab, a monoclonal antibody that targets specific immune cells, has shown effectiveness in treating refractory AIHA and may be used in cases where conventional therapies fail. For individuals with hemolytic anemia caused by an underlying infection, such as malaria, the pharmacological approach involves treating the infection itself. Anti-malarial drugs like chloroquine or artemisinin-based therapies are used to target the malaria parasite and halt the destruction of red blood cells. Similarly, antibiotics or antiviral medications may be used if the hemolysis is a result of bacterial or viral infections, aiming to control the infection and prevent further red blood cell damage. In some cases, particularly in individuals with enzyme deficiencies like glucose 6-phosphate dehydrogenase (G6PD) deficiency, pharmacological treatment is focused on avoiding triggers that can induce hemolysis, such as certain medications, foods, or infections. In these situations, no specific pharmacological agents may be required unless the individual experiences a hemolytic crisis, in which case blood transfusions and supportive care may be necessary. For more severe forms of hemolytic anemia, such as hereditary conditions, or those requiring long-term management, blood transfusions are often used to replace lost red blood cells. This may be combined with medications to manage iron levels, such as iron chelation therapy, to prevent iron overload, which can occur with frequent transfusions. Pharmacological treatments for hemolytic anemia are often used in combination with other therapies, such as splenectomy, blood transfusions, and supportive care, to provide comprehensive management tailored to the individual's specific condition. Early diagnosis and appropriate medication can significantly improve the prognosis and quality of life for those affected by hemolytic anemia. Blood transfusions and their role. Blood transfusions play a crucial role in the treatment of hemolytic anemia, especially in cases where the body's ability to produce red blood cells is overwhelmed or insufficient to meet the demands of the body. Hemolytic anemia leads to the rapid destruction of red blood cells, which can result in severe anemia and a shortage of oxygen-carrying cells. Blood transfusions are a therapeutic option to restore healthy red blood cells and help alleviate symptoms of the condition, such as fatigue, shortness of breath, and weakness. For individuals with severe or symptomatic hemolytic anemia, blood transfusions provide immediate relief, by increasing the number of red blood cells circulating in the bloodstream. This improves the oxygen-carrying capacity of the blood, which helps to reverse symptoms of oxygen deprivation and stabilize the individual's condition. Transfusions are particularly important in acute cases of hemolysis, where the loss of red blood cells is rapid, and the body cannot compensate fast enough through the natural production of new cells. In conditions such as thalassemia or sickle cell disease, where chronic hemolysis and anemia occur, regular blood transfusions may be required to maintain normal red blood cell levels. This is especially true when the body's bone marrow cannot produce enough red blood cells to keep up with the ongoing destruction. In these cases, blood transfusions are often part of long-term management, helping to reduce complications related to severe anemia, such as organ damage or heart failure. However, repeated blood transfusions can lead to a complication known as iron overload. As each transfusion introduces iron into the bloodstream, the body can accumulate excess iron, which can be harmful to organs like the liver, heart, and pancreas. To manage this risk, individuals who undergo regular blood transfusions often receive iron chelation therapy to remove excess iron from the body and prevent organ damage. Blood transfusions also play a supportive role in the management of hemolytic crises, where an individual experiences a sudden and severe drop in red blood cell count. In these situations, transfusions can provide life-saving support, stabilizing the patient while the underlying cause of the hemolysis is treated or managed. While blood transfusions are an essential treatment for many individuals with hemolytic anemia, they are typically used in conjunction with other therapies, such as medications, to address the root cause of the condition. The use of transfusions must be carefully monitored to prevent complications like iron overload and ensure optimal patient care. Emerging therapies and innovations. As research into hemolytic anemia continues to advance, new therapies and innovations are emerging that promise to improve the management of this complex condition. These therapies aim to address the underlying causes of hemolysis more effectively, reduce the need for traditional treatments like blood transfusions, and enhance patients' quality of life. While some of these treatments are still in the experimental or clinical trial stages, they represent promising directions for the future of hemolytic anemia care. One of the most exciting developments in the treatment of hemolytic anemia is the use of gene therapy, particularly for inherited forms of the disease. For conditions like sickle cell anemia and thalassemia, where genetic mutations cause red blood cell destruction, gene editing techniques such as CRISPR-Cas9 are being explored to correct the underlying genetic defects. This approach has the potential to offer a permanent cure, eliminating the need for lifelong blood transfusions and reducing the risk of complications such as iron overload. Clinical trials are already showing encouraging results, and gene therapy may become a standard treatment option in the near future. Another area of innovation is the development of novel biologic therapies aimed at modulating the immune system in autoimmune hemolytic anemia, AIHA. Biologics like rituximab, a monoclonal antibody that targets specific immune cells, are already being used in some cases to treat AIHA. However, researchers are exploring additional biologic agents that can more selectively target the immune pathways responsible for the destruction of red blood cells. These therapies could offer more targeted and less toxic alternatives to traditional immunosuppressive drugs, providing better outcomes with fewer side effects. Additionally, advances in iron chelation therapy are improving the management of iron overload in patients who receive frequent blood transfusions. Newer oral chelating agents, such as deferricerox, are being developed to provide more convenient and effective ways to manage excess iron, reducing the need for intravenous treatments. These therapies not only help prevent the long-term complications of iron overload, such as heart or liver damage, but they also make it easier for patients to adhere to their treatment regimens. In the realm of supportive care, researchers are investigating the potential benefits of stem cell therapy and regenerative medicine for patients with severe hemolytic anemia. These therapies aim to stimulate the production of healthy red blood cells or repair damaged bone marrow, offering hope for individuals with bone marrow failure or chronic hemolysis. Overall, emerging therapies and innovations in hemolytic anemia treatment hold the potential to transform the way this condition is managed. As research progresses and new treatments are developed, patients can look forward to more effective, personalized, and less invasive options that address both the symptoms and causes of hemolytic anemia. Chapter 6: Complications of Hemolytic Anemia. Hemolytic anemia can lead to a variety of complications, many of which stem from the chronic destruction of red blood cells and the body's struggle to maintain an adequate supply. When red blood cells are destroyed faster than they can be replaced, oxygen delivery to tissues becomes impaired, and the body must work harder to compensate. Over time, this imbalance can lead to several short-term and long-term health issues that affect various organs and systems. One of the most immediate complications is severe anemia, which can cause profound fatigue, weakness, shortness of breath, and heart palpitations. If left untreated, the heart may become strained as it attempts to pump more blood to deliver sufficient oxygen throughout the body. This can result in cardiomegaly, or an enlarged heart, and may ultimately lead to heart failure if the anemia is chronic and not properly managed. Another common complication is jaundice, which occurs due to the excessive breakdown of hemoglobin. As red blood cells are destroyed, their contents are released into the bloodstream, including bilirubin, a yellow pigment. When the liver cannot process the elevated levels of bilirubin quickly enough, it accumulates in the skin and eyes, resulting in the yellow discoloration characteristic of jaundice. In some cases, this buildup can also lead to gallstones, which are formed from excess bilirubin and can cause abdominal pain or require surgical intervention. Individuals with hemolytic anemia are also at risk of developing splenomegaly, or an enlarged spleen. The spleen is one of the body's primary sites for filtering and destroying old or damaged red blood cells. When hemolysis is excessive, the spleen becomes overworked and inflamed, sometimes leading to hypersplenism, a condition in which the spleen begins to destroy not only red blood cells but also platelets and white blood cells. This can contribute to bleeding problems, increased susceptibility to infections, and further worsening of anemia. Iron overload is another significant complication, particularly in patients who require frequent blood transfusions. While transfusions are critical for maintaining red blood cell counts, they also introduce excess iron into the body. Without proper management, this iron accumulates in organs such as the liver, heart, and endocrine glands, potentially causing organ damage, hormonal imbalances, or even life-threatening conditions like liver cirrhosis or cardiomyopathy. Finally, in inherited forms of hemolytic anemia like sickle cell disease, repeated episodes of red cell destruction can lead to chronic pain, stroke, delayed growth in children, and damage to vital organs including the kidneys and lungs. Proper monitoring, early intervention, and a comprehensive treatment plan are key to minimizing these complications and improving long-term outcomes for individuals living with hemolytic anemia. Organ damage and failure. One of the most serious consequences of hemolytic anemia is the potential for organ damage and failure, especially when the condition is chronic or poorly managed. As red blood cells are destroyed faster than they can be replaced, the body's tissues and organs may not receive enough oxygen, leading to long-term complications that affect vital systems. The severity of organ involvement varies depending on the type and duration of anemia, as well as the individual's overall health and access to treatment. The heart is often one of the first organs affected. In response to anemia, the heart increases its workload to deliver more oxygen-rich blood throughout the body. Over time, this extra effort can lead to complications such as left ventricular hypertrophy, where the heart's walls thicken due to overuse. If the anemia persists, the heart may eventually weaken, leading to heart failure, especially in cases where transfusions or iron management are not properly administered. The liver is another organ at high risk, particularly due to iron overload. When individuals with hemolytic anemia receive frequent blood transfusions, the body may accumulate more iron than it can eliminate. This excess iron often settles in the liver, causing inflammation, fibrosis, or even cirrhosis. If left unchecked, liver function may deteriorate, potentially progressing to liver failure. Iron-induced liver damage is a significant concern and requires consistent monitoring and treatment with iron chelation therapy. The kidneys also face increased strain in hemolytic anemia. The breakdown of red blood cells releases hemoglobin into the bloodstream, and the kidneys are tasked with filtering it out. High levels of free hemoglobin can be toxic to the kidneys, potentially leading to acute kidney injury. In chronic cases, this damage can accumulate and result in long-term kidney dysfunction or failure. Additionally, dehydration and infections, common in some forms of anemia, can worsen kidney stress and contribute to their decline. The spleen, which filters and removes damaged red blood cells, can become enlarged and overactive. This condition, known as hypersplenism, can cause the spleen to start destroying not just red cells, but also white cells and platelets, increasing the risk of infection and bleeding. In some cases, this may necessitate a surgical procedure to remove the spleen, which then increases the risk of certain bacterial infections. Long-term oxygen deprivation can also affect the brain and nervous system, increasing the risk of stroke, particularly in individuals with sickle cell anemia. These events can cause permanent neurological deficits if not addressed quickly. Overall, organ damage and failure represent some of the most life-threatening aspects of hemolytic anemia, underscoring the importance of timely diagnosis, ongoing monitoring, and comprehensive care. Increased risk of infections. Individuals with hemolytic anemia often face an increased risk of infections due to a combination of factors related to both the disease itself and its treatment. The body's immune defenses can become compromised as a result of ongoing red blood cell destruction, immune system dysfunction, and damage to organs responsible for fighting pathogens. This vulnerability makes preventing and managing infections a critical part of overall care. One key contributor to this elevated risk is an overactive or enlarged spleen, which is common in many forms of hemolytic anemia. The spleen plays a central role in filtering out bacteria and mounting an immune response to infection. However, when it becomes enlarged or begins to malfunction, a condition known as hypersplenism, it may start removing healthy white blood cells from circulation along with the red cells. White blood cells are essential for fighting infection, and their reduced numbers leave the body more susceptible to bacterial and viral illnesses. In some cases, individuals may undergo splenectomy, the surgical removal of the spleen, to reduce red cell destruction. While this can be beneficial in managing anemia, it significantly increases the long-term risk of certain infections, particularly from encapsulated bacteria such as Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. Without the spleen's protective filtering function, these organisms can cause severe, rapid-onset infections that require prompt medical attention. Vaccinations and prophylactic antibiotics are often prescribed to mitigate this risk after splenectomy. Additionally, patients with autoimmune hemolytic anemia (AIHA) may be treated with immunosuppressive therapies such as corticosteroids or monoclonal antibodies like rituximab. While these medications are effective at controlling the immune system's attack on red blood cells, they also reduce the body's ability to fight off infections. This suppression of immune function can lead to a higher incidence of opportunistic infections and longer recovery times. Chronic anemia also weakens the body's general resilience to illness. When tissues and organs are deprived of oxygen due to insufficient red blood cells, the body's overall ability to respond to stressors, including pathogens, is diminished. This can make even common infections more severe and harder to treat in individuals with hemolytic anemia. For these reasons, managing infection risk is a central part of treatment. Preventive measures such as up-to-date vaccinations, careful use of immunosuppressants, and close monitoring of white blood cell levels are essential. In some cases, regular screening and early intervention with antibiotics may be necessary to prevent complications from infections. A proactive approach to infection prevention can greatly improve outcomes and quality of life for those living with hemolytic anemia. Impact on daily life and quality of life. Living with hemolytic anemia can significantly affect a person's daily life and overall quality of life. The physical symptoms, emotional strain, and social challenges associated with the condition often require ongoing adjustments, both mentally and physically. While the degree of impact varies between individuals and the severity of their condition, the challenges are often persistent and wide-ranging. Fatigue is one of the most commonly reported symptoms and can interfere with nearly every aspect of daily functioning. Individuals may find it difficult to complete routine tasks, maintain regular employment, or participate in social activities. Even mild exertion can lead to exhaustion, creating a cycle of physical limitation and frustration. This constant fatigue can also contribute to sleep disturbances, compounding the feeling of weariness and affecting mental clarity and mood. Chronic hemolytic anemia often brings about an emotional toll. The unpredictability of flare-ups or complications may cause anxiety and stress. Individuals may worry about their health stability, treatment outcomes, or long-term prognosis. Depression is also not uncommon, especially in those who feel isolated or unable to engage fully in their personal or professional lives. The psychological burden of living with a chronic illness can be just as challenging as the physical symptoms, requiring support from mental health professionals, support groups, or trusted family and friends. Social limitations are another significant factor. Many individuals with hemolytic anemia must schedule their lives around frequent medical appointments, blood transfusions, or treatment regimens. This can make spontaneous activities or travel difficult. Children and teenagers may miss school or have trouble keeping up with their peers academically and socially, while adults might struggle to maintain full-time jobs or manage responsibilities at home. Additionally, dietary restrictions, infection risk, and side effects from medications can further disrupt normal life. Some patients need to avoid certain foods or substances that could trigger hemolysis. Others may be more susceptible to illnesses and have to be cautious in crowded or high-risk environments. The ongoing vigilance required to manage the condition can be mentally draining. Despite these challenges, many individuals with hemolytic anemia lead fulfilling lives with proper medical care, emotional support, and lifestyle adaptations. Advances in treatment and a growing understanding of patient needs are helping to improve outcomes and reduce the daily burdens associated with the disease. Empowerment through education, strong healthcare partnerships, and community connections can all enhance the quality of life for those managing hemolytic anemia. Chapter 7: Hemolytic Anemia in Special Populations. Hemolytic anemia affects individuals differently, depending on their age, underlying health conditions, and life circumstances. Certain populations face unique challenges related to diagnosis, treatment, and disease management. These include infants, pregnant individuals, the elderly, and those with other coexisting health conditions. Understanding how hemolytic anemia presents and progresses in these groups is essential for providing targeted and effective care. In newborns and infants, hemolytic anemia can develop due to inherited conditions such as glucose 6-phosphate dehydrogenase (G6PD) deficiency or hereditary spherocytosis. In some cases, hemolysis may also result from Rh incompatibility between the mother and child, a condition known as hemolytic disease of the newborn. These infants may show signs of jaundice, pale skin, or poor feeding in the first few days of life. Early detection through prenatal testing and newborn screenings is critical to prevent severe complications, including brain damage from high bilirubin levels. Treatments often involve phototherapy, blood transfusions, or exchange transfusions in severe cases. Pregnancy presents a complex scenario for individuals with hemolytic anemia. The increased blood volume and physiological demands of pregnancy can worsen anemia symptoms. Women with inherited forms of hemolytic anemia, such as sickle cell disease or thalassemia, require close monitoring to avoid complications like preterm birth, preeclampsia, and low birth weight. Managing these pregnancies involves a multidisciplinary approach that includes hematologists, obstetricians, and maternal-fetal specialists. Careful planning before and during pregnancy helps ensure better outcomes for both mother and baby. The elderly population may also face greater difficulties in managing hemolytic anemia. Age-related decline in bone marrow function and the presence of multiple comorbidities can complicate diagnosis and treatment. Fatigue and weakness caused by anemia may overlap with other health issues common in older adults, making the condition harder to identify. Furthermore, elderly individuals may be more sensitive to medication side effects and less tolerant of frequent hospital visits or transfusions. Personalized treatment plans that consider age-related risks and the patient's overall health are vital for this group. People with underlying autoimmune diseases, such as lupus or rheumatoid arthritis, are also more likely to develop autoimmune hemolytic anemia. In these cases, managing the primary autoimmune disorder is key to controlling hemolysis. Immunosuppressive therapies must be used carefully to balance efficacy and infection risk. Special populations require tailored approaches to care, with a focus on early diagnosis, comprehensive management, and coordination among healthcare providers. Recognizing the specific needs of these individuals improves prognosis and enhances their overall quality of life. Hemolytic anemia in children. Hemolytic anemia in children presents unique challenges that require careful attention from both healthcare providers and caregivers. The condition can be inherited or acquired, and its symptoms may be more difficult to identify in younger patients who cannot fully express how they feel. Early recognition, accurate diagnosis, and ongoing support are essential to ensure healthy growth and development in affected children. Inherited forms of hemolytic anemia are among the most common in pediatric cases. Conditions like sickle cell anemia, thalassemia, hereditary spherocytosis, and glucose 6-phosphate dehydrogenase (G6PD) deficiency often appear in infancy or early childhood. These disorders cause red blood cells to be more fragile or abnormal in shape, making them prone to premature destruction. Depending on the severity of the disease, children may experience chronic fatigue, jaundice, pale skin, delayed growth, or frequent infections. Acquired forms of hemolytic anemia in children can result from autoimmune reactions, infections, or exposure to certain medications. Autoimmune hemolytic anemia (AIHA) is rare in children but can occur suddenly and progress rapidly. It may follow a viral illness and can lead to severe anemia if not treated promptly. In such cases, corticosteroids are often the first line of treatment, and immunosuppressive drugs may be used for long-term management. Diagnosing hemolytic anemia in children can be complex due to overlapping symptoms with other childhood illnesses. Blood tests, including a complete blood count (CBC), reticulocyte count, and peripheral blood smear, help identify the nature and cause of the anemia. Genetic testing may also be necessary for suspected inherited forms. Pediatric hematologists often guide the diagnosis and treatment process, ensuring that all potential factors are considered. Managing hemolytic anemia in children involves more than just treating symptoms. It requires a comprehensive approach that includes monitoring for complications, maintaining proper nutrition, and supporting normal development. Some children may need regular blood transfusions, iron chelation therapy, or surgical removal of the spleen if it becomes overactive. Vaccinations and preventive antibiotics are important for those with compromised immune function or after a splenectomy. Emotional and psychological support is equally important, especially for school-aged children who may struggle with fatigue or miss activities due to hospital visits. Education for families and teachers can help create a more understanding and supportive environment for the child. With appropriate care and consistent follow-up, many children with hemolytic anemia can lead active and fulfilling lives. Advances in treatment and early intervention strategies continue to improve outcomes for pediatric patients living with this condition. Hemolytic anemia in pregnant women. Hemolytic anemia during pregnancy presents a unique clinical challenge, as it requires balancing the health and safety of both the mother and the developing fetus. Pregnancy naturally increases the body's demand for red blood cells, and when hemolysis is present, the body may struggle to meet this demand. This can result in more pronounced anemia and an elevated risk of complications for both the parent and baby. There are both inherited and acquired forms of hemolytic anemia that can affect pregnant women. Inherited conditions such as sickle cell disease or thalassemia may already be present before pregnancy and often require close monitoring and management throughout gestation. These conditions can lead to complications including pain crises, increased risk of infections, and preeclampsia. In contrast, acquired hemolytic anemia, such as autoimmune hemolytic anemia, AIHA, can develop during pregnancy, sometimes triggered by immune system changes that occur naturally as the body adjusts to pregnancy. Symptoms of hemolytic anemia in pregnant women often include fatigue, pallor, shortness of breath, and jaundice. These symptoms can sometimes be mistaken for normal pregnancy-related changes, making diagnosis more challenging. Blood tests are essential for identifying signs of increased red cell destruction, including elevated bilirubin levels, a high reticulocyte count, and the presence of abnormal red cells on a blood smear. Treatment depends on the underlying cause and severity of the condition. For autoimmune cases, corticosteroids are commonly used to suppress immune-mediated destruction of red cells. In more severe or resistant cases, immunosuppressive therapies or intravenous immunoglobulin, IVIG, may be needed. Blood transfusions are sometimes required to stabilize hemoglobin levels, particularly before delivery. Each treatment choice must be carefully considered to minimize any risk to the developing fetus, while effectively managing the mother's condition. Hemolytic anemia in pregnancy increases the likelihood of complications such as intrauterine growth restriction, preterm birth, and low birth weight. It can also contribute to maternal complications like preeclampsia or increased susceptibility to infections. As a result, pregnant women with hemolytic anemia often require multidisciplinary care involving obstetricians, hematologists, and maternal-fetal medicine specialists. With vigilant prenatal care, regular monitoring, and individualized treatment plans, many women with hemolytic anemia can have safe pregnancies and healthy deliveries. Early planning and communication between the patient and healthcare team are essential to managing risks and supporting positive outcomes for both mother and child. Hemolytic anemia in older adults. Hemolytic anemia in older adults can present significant diagnostic and therapeutic challenges due to age-related physiological changes, comorbidities, and altered immune function. This population is more likely to experience complications from both the anemia itself and the treatments used to manage it. Recognizing how hemolytic anemia manifests in older individuals is essential for timely diagnosis and effective management. In elderly patients, hemolytic anemia may be either acquired or secondary to underlying conditions such as autoimmune disorders, malignancies, or infections. Autoimmune hemolytic anemia, AIHA, is one of the more common acquired forms seen in this age group and often arises without a clear cause. However, it may also be linked to lymphoproliferative diseases like chronic lymphocytic leukemia, KA, or certain medications that trigger an immune response against red blood cells. Symptoms in older adults may be subtle or mistakenly attributed to aging or other chronic illnesses. Common signs include fatigue, weakness, pale or jaundiced skin, and shortness of breath. In some cases, hemolytic anemia may be discovered incidentally during routine blood work. Because the bone marrow's regenerative capacity may be diminished with age, even a mild degree of hemolysis can lead to significant anemia in elderly individuals. Diagnosis typically involves a combination of laboratory tests including complete blood count, reticulocyte count, bilirubin levels, lactate dehydrogenase (LDH), haptoglobin, and direct antiglobulin (CUMS) testing. Additional imaging or bone marrow biopsy may be necessary if an underlying hematologic disorder is suspected. Treatment strategies must be carefully tailored for older adults. Corticosteroids are often the first-line therapy for autoimmune hemolytic anemia, but can carry risks such as osteoporosis, elevated blood sugar, and increased susceptibility to infections. Immunosuppressive medications or monoclonal antibodies like rituximab may be considered in refractory cases, though they also come with added risks in this population. Blood transfusions can offer rapid symptom relief, but require monitoring for cardiovascular strain, which is especially important in patients with heart disease. Managing hemolytic anemia in older adults also involves addressing the broader context of the patient's health, including nutritional status, functional capacity, and support systems. Coordination among specialists, including hematologists, geriatricians, and primary care providers, ensures comprehensive care. Although hemolytic anemia can significantly impact quality of life in older adults, early diagnosis and careful individualized treatment planning can lead to positive outcomes. With appropriate support, many elderly patients can manage their condition effectively and maintain independence. Chapter 8: Managing Hemolytic Anemia. Managing hemolytic anemia requires a multifaceted approach that addresses both the underlying cause and the symptoms associated with increased red blood cell destruction. Effective management involves ongoing monitoring, appropriate therapeutic interventions, lifestyle adjustments, and patient education. Because the condition can be either chronic or episodic, treatment strategies often need to be flexible and individualized. The first step in management is identifying the specific type and cause of hemolytic anemia. In cases where the anemia is inherited, such as sickle cell disease or thalassemia, long-term care involves preventive strategies and routine surveillance to avoid complications. For autoimmune or acquired types, the focus is often on controlling the immune response or eliminating the triggering factor, such as a medication or underlying illness. Pharmacological treatments are a central part of managing hemolytic anemia. These can include corticosteroids to suppress immune-mediated hemolysis, immunosuppressive drugs for chronic autoimmune cases, and folic acid supplements to support red blood cell production. In certain severe cases, monoclonal antibodies like rituximab or chemotherapy agents may be used, especially when associated with other autoimmune or hematologic diseases. For patients experiencing acute drops in hemoglobin levels or symptomatic anemia, blood transfusions can provide rapid relief. However, the use of transfusions must be carefully monitored to prevent complications such as iron overload or transfusion reactions. Iron chelation therapy may be required in individuals who receive frequent transfusions to avoid damage from excess iron buildup. Lifestyle management also plays an important role in long-term care. Patients are encouraged to maintain a balanced diet rich in iron, folate, and vitamin B12, though iron supplementation should only be taken under medical supervision. Hydration, rest, and avoiding known triggers such as infections or certain drugs can help reduce the frequency of flare-ups in some patients. Patient education and regular follow-up are essential. Individuals living with hemolytic anemia need to understand their condition, recognize early warning signs of complications, and adhere to their treatment regimens. Healthcare providers often work closely with patients to adjust therapy based on lab values and symptoms, ensuring optimal outcomes. Psychosocial support is equally important, especially for those coping with chronic forms of the disease. Emotional stress, physical limitations, and uncertainty about flare-ups can affect quality of life. Support groups, counseling, and accessible care teams can make a meaningful difference in how patients manage the emotional aspects of their condition. Overall, managing hemolytic anemia involves not only treating the disease itself, but also supporting the individual as a whole. With coordinated care and a proactive approach, many patients are able to lead healthy and fulfilling lives. Lifestyle modifications. Adopting the right lifestyle modifications can play a significant role in supporting individuals living with hemolytic anemia. While medical treatments address the underlying causes and symptoms, everyday habits and choices can influence how well a person manages the condition and prevents complications. These modifications are particularly important for individuals dealing with chronic or recurring hemolytic episodes. Nutrition is a cornerstone of lifestyle management for those with hemolytic anemia. A diet rich in folate, vitamin B12, and iron, when appropriate, is essential for supporting healthy red blood cell production. Leafy greens, legumes, whole grains, lean proteins, and fortified cereals are beneficial food sources. However, iron supplementation and iron-rich diets should only be pursued under medical supervision, especially for those who receive regular transfusions and are at risk of iron overload. Staying hydrated is another key factor, especially for individuals with conditions like sickle cell disease, where dehydration can trigger or worsen episodes of hemolysis. Drinking adequate fluids throughout the day helps maintain optimal blood flow and reduces the likelihood of complications. Physical activity can contribute to overall well-being, but it should be approached with care. Moderate exercise, such as walking, swimming, or yoga, can help improve circulation and energy levels without placing excessive strain on the body. Patients should avoid overly strenuous activities during periods of low hemoglobin or active symptoms, as fatigue and shortness of breath may worsen. Sleep and rest are essential for recovery and daily functioning. Individuals with hemolytic anemia often experience fatigue, so ensuring adequate rest and maintaining a consistent sleep schedule can help improve energy levels and mood. Stress management is also crucial, as physical and emotional stress can sometimes exacerbate hemolytic activity. Techniques like meditation, deep breathing exercises, or engaging in enjoyable hobbies may provide relief and emotional balance. Avoiding triggers is another important lifestyle consideration. Some medications, infections, and environmental exposures can provoke hemolysis, particularly in people with enzyme deficiencies like G6PD deficiency. Patients should work closely with their healthcare providers to identify and avoid such triggers. Vaccinations and good hygiene practices can help reduce the risk of infections, which are common culprits in worsening symptoms. Regular medical follow-ups and open communication with healthcare providers are essential parts of a sustainable lifestyle. Tracking symptoms, understanding treatment options, and having a plan for managing flare-ups contribute to a greater sense of control and confidence in handling the condition. Overall, integrating thoughtful lifestyle modifications into daily routines empowers individuals with hemolytic anemia to improve their health, reduce complications, and enhance their quality of life. Monitoring and preventive care. Effective monitoring and preventive care are vital for individuals with hemolytic anemia, as they help manage the condition, reduce complications, and improve quality of life. Regular monitoring allows healthcare providers to track the progression of the disease, adjust treatment plans as needed, and prevent or address any emerging issues before they become severe. For individuals with chronic or recurring hemolytic anemia, routine blood tests are essential. These tests typically include a complete blood count (CBC) to monitor hemoglobin levels, reticulocyte counts to assess bone marrow activity, and markers such as bilirubin and lactate dehydrogenase (LDH) to track red blood cell destruction. These tests help ensure that the anemia is being managed effectively and that early signs of complications, such as iron overload or organ damage, are detected promptly. Preventive care is equally important in managing hemolytic anemia. For example, individuals with autoimmune hemolytic anemia may need to take immunosuppressive medications to prevent further destruction of red blood cells. Regular follow-ups with hematologists and other specialists are necessary to monitor the effectiveness of these treatments and to adjust dosages when needed. In cases of inherited hemolytic anemia, such as sickle cell disease or thalassemia, regular monitoring for complications like organ damage, pain crises, and infections is also critical. Vaccination plays a key role in preventive care, especially for individuals with splenectomy or those at higher risk of infection. Pneumococcal, meningococcal, and influenza vaccines are often recommended to reduce the risk of serious infections. Preventive antibiotics may also be prescribed for some individuals to lower the risk of infections, particularly for those with weakened immune systems. For individuals who receive frequent blood transfusions, iron overload can become a concern. Preventive care for iron overload typically includes regular monitoring of iron levels and the use of iron chelation therapy when needed. This helps prevent long-term damage to organs like the liver and heart. Lifestyle adjustments, as mentioned earlier, also play an important role in prevention. Ensuring a balanced diet, staying hydrated, and avoiding triggers that may lead to hemolysis can significantly reduce the frequency and severity of episodes. In conclusion, a proactive approach to monitoring and preventive care allows individuals with hemolytic anemia to lead healthier lives. By staying vigilant and working closely with healthcare providers, patients can manage their condition effectively, minimize complications, and maintain their well-being. Psychological and emotional support. Living with hemolytic anemia can be physically and emotionally challenging, particularly for individuals managing chronic or severe forms of the condition. The physical symptoms, such as fatigue and pain, often intersect with emotional strain, leading to a complex psychological experience. As such, psychological and emotional support is a critical aspect of comprehensive care for those affected by hemolytic anemia. The uncertainty of flare-ups, the impact on daily functioning, and the potential for long-term health complications can lead to feelings of anxiety, depression, and isolation. People living with the condition may also experience frustration with the unpredictability of symptoms or the limitations imposed by treatments. These emotional challenges are not only a consequence of the disease itself, but also of the social and lifestyle adjustments that may be required. One of the key ways to address these emotional aspects is through open communication with healthcare providers. Encouraging patients to discuss their feelings, concerns, and stressors helps foster a sense of control and understanding. Physicians and specialists who listen actively and validate the emotional toll of the disease can help reduce feelings of isolation and promote a more holistic approach to treatment. Psychological support can also come from mental health professionals, such as counselors, psychologists, or therapists, who can help patients develop coping strategies for dealing with anxiety, depression, or stress. Cognitive behavioral therapy, CBT, is one of the most effective therapeutic approaches for addressing the emotional challenges of chronic illness. CBT helps individuals reframe negative thoughts, manage stress, and improve emotional resilience. Support groups, either in person or online, provide a sense of community for individuals with hemolytic anemia. Sharing experiences with others who understand the challenges of the disease can be incredibly validating. Support groups also offer opportunities for practical advice, emotional encouragement, and peer connection, all of which can reduce the sense of isolation and increase emotional well-being. Additionally, family and friends play a crucial role in emotional support. Loved ones who are educated about hemolytic anemia and its impact can offer empathy and practical assistance. Emotional support from family and friends helps patients feel more empowered and less burdened by their condition. In conclusion, psychological and emotional support are essential components of managing hemolytic anemia. By fostering an environment of understanding, providing access to mental health resources, and cultivating strong support networks, individuals living with hemolytic anemia can better cope with the emotional aspects of their condition, ultimately improving their quality of life. Conclusion: hemolytic anemia is a complex and multifaceted condition that requires careful management to ensure optimal patient outcomes. From understanding the biology of red blood cells to recognizing the various causes, symptoms, and treatment options, it becomes clear that a comprehensive approach to care is essential. While the medical community has made significant strides in diagnosing and treating hemolytic anemia, it is equally important to consider the emotional and psychological well-being of individuals living with the condition. Early diagnosis, effective treatment plans, and continuous monitoring are key to managing hemolytic anemia. Pharmacological treatments, blood transfusions, and emerging therapies can provide critical relief and improve the quality of life for patients. However, the journey doesn't end with medical care. Lifestyle modifications, preventive care, and emotional support are just as important in maintaining long-term health and well-being. Patients benefit from adopting healthy habits, staying informed about their condition, and having access to supportive networks that help them navigate the challenges of living with hemolytic anemia. Equally significant is the need for individualized care, as the disease manifests differently across various populations, including children, pregnant women, and older adults. Tailoring treatment and management strategies to the specific needs of these groups ensures that care is both effective and compassionate. The future of hemolytic anemia care looks promising, with new therapies on the horizon and an increased focus on personalized medicine. As research continues to uncover the complexities of this condition, we can expect more targeted treatments and better outcomes for patients. In conclusion, while hemolytic anemia presents a variety of challenges, with proper management, emotional support, and ongoing medical care, individuals affected by this condition can lead fulfilling lives. By addressing both the physical and emotional aspects of the disease, we ensure that those living with hemolytic anemia have the tools and resources they need to thrive.
Chapter 1: Introduction to Nutritional Anemia. Nutritional anemia is a significant public health challenge, especially in developing nations where poverty, limited access to nutritious food, and inadequate healthcare infrastructure are common. It refers to a group of anemias caused by a deficiency in essential nutrients required for red blood cell production, most notably iron, folate, and vitamin B12. This condition is characterized by a reduced number of red blood cells or hemoglobin, which diminishes the blood's capacity to carry oxygen, leading to fatigue, weakness, and a host of other health complications. In the broader context of global health, nutritional anemia has persisted as a silent epidemic. Historical records from the 20th century show that while infectious diseases garnered most of the global health attention, the slow-moving, debilitating effects of anemia quietly impaired millions, particularly in regions already burdened by malnutrition. In the modern era, it remains a key indicator of a population's nutritional status and the efficacy of public health interventions. According to global health data, over 2 billion people suffer from some form of anemia, with the highest rates found in South Asia, Sub-Saharan Africa, and parts of Latin America. The significance of tackling nutritional anemia in developing nations cannot be overstated. It disproportionately affects the most vulnerable populations, pregnant women, young children, and the elderly, undermining their growth, productivity, and overall well-being. For children, anemia can impair cognitive development, stunting both mental and physical growth. In pregnant women, it increases the risk of maternal mortality, preterm births, and low birth weight. These consequences not only have personal and familial implications, but also create economic burdens for communities and nations, perpetuating cycles of poverty and underdevelopment. Despite its prevalence, nutritional anemia often remains underdiagnosed and undertreated in resource-limited settings. This is due in part to the nonspecific nature of its symptoms, which can be mistaken for other conditions or overlooked entirely. Additionally, limited access to diagnostic tools, nutritional supplements, and healthcare services creates barriers to early intervention and effective treatment. Cultural beliefs, dietary restrictions, and gender-based disparities in food distribution further complicate the issue. This chapter sets the foundation for a deeper exploration into the multifaceted nature of nutritional anemia. By understanding what it is, where it stems from, and why it is particularly severe in developing countries, we can begin to examine the broader systemic issues that sustain it. The following chapters will delve into the causes, epidemiology, societal impacts, and the global efforts being made to combat this persistent yet preventable condition. Definition and classification of anemia. Anemia is a condition characterized by a decrease in the number of red blood cells, or the concentration of hemoglobin in the blood, resulting in reduced oxygen-carrying capacity. This deficit hampers the body's ability to deliver adequate oxygen to tissues and organs, leading to symptoms such as fatigue, weakness, shortness of breath and pallor. While it may present mildly at first, untreated anemia can progress and contribute to severe health complications, particularly in vulnerable populations like children, pregnant women, and the elderly. The World Health Organization defines anemia based on hemoglobin concentration thresholds that vary by age, sex, and physiological status. For example, hemoglobin levels below 12 grams per deciliter in non-pregnant women and below 13 grams per deciliter in men typically indicate anemia. These thresholds provide a standardized framework for diagnosis across different settings and populations, although local health systems may adjust these values based on regional health patterns and altitude. Anemia is not a singular disease, but rather a symptom of various underlying conditions. It is broadly classified into several categories based on cause and red blood cell morphology. The three main types include nutritional anemia, hemolytic anemia, and anemia of chronic disease. Nutritional anemia, the primary focus of this book, arises due to deficiencies in essential nutrients, primarily iron, vitamin B12, and folic acid, that are critical for red blood cell production. This form of anemia is the most prevalent globally, and is strongly associated with inadequate dietary intake, poor absorption, or increased physiological demand. Hemolytic anemia, on the other hand, is characterized by the premature destruction of red blood cells, which may be due to inherited conditions such as sickle cell disease or thalassemia, or acquired causes like infections, autoimmune reactions, or exposure to certain drugs and toxins. Anemia of chronic disease typically occurs in the context of long-standing illnesses such as cancer, HIV/AIDS, tuberculosis, or inflammatory disorders. It is usually driven by impaired iron metabolism and reduced red blood cell production due to chronic inflammation. In addition to etiological classification, anemia is also categorized based on red blood cell size, microcytic, normocytic, and macrocytic. Microcytic anemia, often resulting from iron deficiency, is characterized by smaller than normal red cells. Macrocytic anemia, usually due to folate or vitamin B12 deficiency, presents with enlarged red cells. Normocytic anemia refers to red blood cells that are normal in size but reduced in number, often seen in anemia of chronic disease. Understanding the definition and classification of anemia is critical for effective diagnosis and treatment. Each type of anemia requires a tailored approach, and accurate classification helps in identifying root causes, guiding interventions, and evaluating public health strategies. This foundational knowledge is essential as we continue exploring the complexities of nutritional anemia in developing regions. Historical context and global burden. Anemia has been recognized as a public health issue for centuries, with early descriptions dating back to ancient medical texts from Egypt, Greece, and China. These early accounts often referred to conditions resembling anemia, though they lacked the scientific understanding we have today. By the 19th and early 20th centuries, medical advancements allowed for a clearer identification of anemia's various forms, particularly iron deficiency anemia. At that time, cases were often associated with poverty, poor sanitation, and inadequate nutrition, issues that continue to plague developing nations in the modern era. The historical context of nutritional anemia is closely tied to the broader history of global inequality. During colonial times, the disruption of traditional agricultural systems and the introduction of cash crops in many developing regions contributed to widespread malnutrition. Local diets, once rich and diverse, were often replaced with monotonous carbohydrate-heavy foods lacking in essential micronutrients. This shift laid the foundation for widespread nutritional deficiencies, including iron deficiency anemia, particularly among women and children. Public health efforts in the mid-20th century began to identify anemia as a critical barrier to national development, linking it to poor school performance, low work productivity, and increased maternal and infant mortality. In the contemporary era, nutritional anemia remains a massive global health challenge. According to the World Health Organization, more than 30% of the world's population is anemic, with the highest prevalence rates found in developing countries across South Asia, Sub-Saharan Africa, and parts of Latin America. Iron deficiency anemia accounts for approximately half of all anemia cases globally, and it disproportionately affects women of reproductive age and children under 5. In many countries, anemia prevalence in these groups exceeds 40%, a level considered a severe public health problem. The global burden of anemia extends beyond health and into economic and social dimensions. Anemic individuals often suffer from reduced physical and cognitive performance, which lowers educational attainment in children and work productivity in adults. This leads to decreased economic output and increased healthcare costs, creating a cycle of poverty and underdevelopment. In regions where healthcare systems are already strained, the widespread prevalence of anemia adds further pressure, complicating efforts to reduce maternal and child mortality and improve quality of life. Addressing the global burden of nutritional anemia requires a multifaceted approach. This includes improving dietary diversity, expanding access to fortified foods, enhancing healthcare services, and addressing underlying socioeconomic inequalities. As we move forward in this book, it is crucial to keep this historical and global perspective in mind to fully grasp the magnitude and complexity of the issue. Importance of addressing nutritional anemia in developing nations. Nutritional anemia is more than just a medical condition. It is a reflection of broader systemic issues that hinder growth and development in many parts of the world. In developing nations, where access to basic healthcare, adequate nutrition, and social support systems is often limited, the consequences of nutritional anemia are far-reaching. It affects not only individual health, but also the economic stability and long-term progress of entire communities. Addressing this condition is essential for breaking the cycle of poverty, improving quality of life, and achieving sustainable development. One of the most urgent reasons to prioritize nutritional anemia in developing nations is its impact on maternal and child health. Pregnant women with anemia are at a higher risk of complications during childbirth, including hemorrhage and death. Anemic mothers are more likely to give birth to low birth weight infants, who themselves face a higher risk of infant mortality, developmental delays, and chronic illness later in life. Children who grow up with anemia often struggle in school due to impaired cognitive development and reduced attention spans, leading to lower educational achievement and fewer economic opportunities in adulthood. Beyond the household, anemia has serious implications for workforce productivity and national economies. Adults suffering from anemia tend to experience fatigue, weakness, and reduced stamina, which affects their ability to work effectively, particularly in labor-intensive industries such as agriculture, manufacturing, and construction. In economies that rely heavily on manual labor, the cumulative effect of an anemic workforce can significantly lower productivity and economic output. This, in turn, can limit a nation's ability to invest in education, infrastructure, and healthcare, further perpetuating cycles of disadvantage. Nutritional anemia also weakens immune systems, making individuals more susceptible to infections and illnesses. In regions where diseases like malaria, tuberculosis, and HIV are prevalent, this vulnerability can lead to a higher disease burden and increased strain on already fragile healthcare systems. The interplay between infection and anemia creates a feedback loop in which each condition exacerbates the other, complicating efforts to reduce morbidity and mortality rates. Efforts to combat nutritional anemia in developing nations are often hindered by limited resources, political instability, and logistical challenges. However, the benefits of addressing the issue are immense. Interventions such as micronutrient supplementation, food fortification, and public health education have been shown to significantly reduce anemia rates and improve health outcomes. By investing in these strategies, governments and international organizations can take a powerful step toward improving population health, promoting gender equality, and fostering economic resilience in the developing world. Chapter 2: Causes of Nutritional Anemia. Nutritional anemia is primarily caused by a deficiency of essential nutrients that are required for the production and maintenance of healthy red blood cells. In developing nations, these deficiencies often arise due to a complex interplay of poor dietary intake, inadequate healthcare, and environmental and socioeconomic challenges. Understanding the causes of nutritional anemia is essential for designing targeted interventions that can address the root of the problem, rather than just its symptoms. Iron deficiency is the most common cause of nutritional anemia, and is often the result of diets that are low in bioavailable iron. In many developing countries, staple diets are predominantly plant-based, relying heavily on cereals and legumes, which contain non-heme iron, a form that is less efficiently absorbed by the body. Furthermore, these foods often contain inhibitors such as phytates and tannins that reduce iron absorption even further. Limited consumption of animal products, which provide more readily absorbed heme iron, exacerbates the deficiency, especially among low-income populations that cannot afford such foods regularly. Folate and vitamin B12 deficiencies are also significant contributors to nutritional anemia. Folate is essential for DNA synthesis and red blood cell formation, and its deficiency can result in megaloblastic anemia, characterized by the presence of abnormally large red blood cells. Folate deficiency is often seen in populations with limited access to fresh fruits and green leafy vegetables. Vitamin B12, which is primarily found in animal-based foods, is particularly lacking in the diets of vegetarians or populations with restricted access to meat, dairy, and eggs. In some cases, poor absorption due to gastrointestinal disorders or parasitic infections also contributes to vitamin B12 deficiency. In addition to dietary causes, chronic blood loss from parasitic infections such as hookworm and schistosomiasis plays a major role in causing and perpetuating anemia, particularly in rural areas with inadequate sanitation. These parasites feed on blood or cause internal bleeding, leading to a significant loss of iron and red blood cells over time. Malaria, another prevalent condition in many developing countries, contributes to anemia by destroying red blood cells and disrupting normal hematopoiesis. Overall, the causes of nutritional anemia in developing nations are multifactorial and often interconnected. Malnutrition, infections, poverty, and poor health infrastructure create a vicious cycle that makes both prevention and treatment challenging. To break this cycle, a comprehensive understanding of these causes must inform public health strategies that address not only nutritional deficits but also the broader systemic issues that sustain them. Iron deficiency and dietary inadequacies. Iron deficiency is the most widespread and well-documented cause of nutritional anemia globally, and it remains especially prevalent in developing nations. Iron is a vital mineral required for the synthesis of hemoglobin, the protein in red blood cells responsible for transporting oxygen throughout the body. When the body lacks sufficient iron, it cannot produce adequate hemoglobin, leading to a reduced oxygen-carrying capacity of the blood and the onset of anemia. The symptoms, such as fatigue, dizziness, shortness of breath, and pallor, can significantly impair daily functioning and quality of life, particularly in physically demanding environments. In many developing countries, the root cause of iron deficiency lies in dietary inadequacies. Diets in low-income regions are often monotonous, relying heavily on staple foods such as rice, maize, or wheat, which contain low levels of bioavailable iron. These grains primarily provide non-heme iron, which is absorbed less efficiently by the body than heme iron found in animal-based products like meat, poultry, and fish. Furthermore, plant-based diets often include substances such as phytates, oxalates, and tannins, commonly found in legumes, tea, and certain vegetables, which inhibit iron absorption in the gastrointestinal tract. As a result, even when iron is present in the diet, it may not be absorbed in adequate quantities. Cultural and economic barriers further complicate the problem. In many households, especially in rural or impoverished areas, animal source foods are consumed sparingly or not at all due to their high cost or due to religious or cultural dietary practices. Women and children are often the most affected, as food distribution within households may favor male members, and the higher iron requirements during menstruation, pregnancy, and early childhood are not met. The consequence is a widespread chronic state of iron deficiency that undermines both physical health and cognitive development. Additionally, frequent illnesses and parasitic infections common in developing countries, such as malaria, hookworm, and chronic diarrhea, can worsen iron deficiency by increasing the body's iron needs or by causing iron loss through internal bleeding and inflammation. These factors compound the effects of a poor diet and make it even harder for the body to maintain healthy iron levels. Addressing iron deficiency through dietary improvement is essential but often challenging in low-resource settings. Strategies such as dietary diversification, iron supplementation, and food fortification with iron have shown success in reducing the burden of iron deficiency anemia. However, these interventions must be paired with broader efforts to combat poverty, improve health education, and ensure access to healthcare to create lasting change. Vitamin B12 and folate deficiencies. Vitamin B12 and folate are essential nutrients required for DNA synthesis, red blood cell formation, and neurological function. Deficiencies in either can result in megaloblastic anemia, a condition characterized by the presence of abnormally large, immature red blood cells in the bone marrow and peripheral blood. While often overshadowed by iron deficiency in public health discourse, B12 and folate deficiencies are significant contributors to the burden of nutritional anemia, particularly in developing nations where access to diverse and nutrient-rich foods is limited. Folate or vitamin B9 is found in a variety of plant-based foods, including leafy green vegetables, legumes, and citrus fruits. However, the availability and consumption of these foods may be inconsistent in many low-income regions due to seasonal variations, poor agricultural infrastructure, and food insecurity. Cooking practices also play a role, as folate is highly sensitive to heat and can be destroyed during prolonged cooking. As a result, even when folate-containing foods are consumed, their nutritional value may be significantly reduced by the time they reach the plate. Vitamin B12, on the other hand, is found almost exclusively in animal source foods such as meat, fish, eggs, and dairy. This makes deficiency more common in populations that rely heavily on plant-based diets, whether due to cultural, religious, or economic reasons. In regions where animal products are scarce or unaffordable, such as parts of South Asia and sub-Saharan Africa, B12 deficiency can be widespread. The problem is particularly concerning for pregnant and lactating women, as well as for infants and young children, whose nutritional needs are higher and more sensitive to deficiency. Beyond dietary causes, absorption issues also contribute to deficiencies. Vitamin B12 requires a specific protein called intrinsic factor for absorption in the small intestine. Infections, gastrointestinal diseases such as atrophic gastritis, and parasitic infestations common in developing countries can impair this process, making B12 deficiency more likely even when dietary intake is sufficient. Folate absorption can similarly be affected by intestinal inflammation or malabsorption syndromes, further compounding the issue in areas where gastrointestinal disorders are prevalent. The consequences of B12 and folate deficiencies extend beyond anemia. Neurological complications, including memory loss, irritability, and in severe cases irreversible nerve damage, are associated with prolonged B12 deficiency. Folate deficiency in pregnancy increases the risk of neural tube defects in infants, making early intervention crucial. Addressing these deficiencies requires a combination of strategies, including education on dietary diversity, food fortification programs, and targeted supplementation for high-risk groups, particularly women and children. Tackling B12 and folate deficiencies is a key step toward a comprehensive solution to nutritional anemia in the developing world. Infections and parasitic contributions. In developing nations, the burden of nutritional anemia is compounded by a high prevalence of infections and parasitic diseases. These health conditions not only weaken the immune system and deplete nutrient stores but also directly impair the body's ability to produce and maintain healthy red blood cells. The link between infection and anemia is particularly strong in environments where sanitation is poor, healthcare access is limited, and malnutrition is already widespread. One of the most significant contributors to anemia in many tropical and subtropical regions is malaria. Caused by the Plasmodium parasite and transmitted by mosquitoes, Malaria destroys red blood cells during its life cycle, leading to acute or chronic anemia depending on the frequency and severity of infection. In children and pregnant women, two of the most vulnerable groups, malaria-associated anemia is a major cause of hospitalization, developmental delays, and maternal mortality. Furthermore, the inflammation caused by malaria can suppress the bone marrow's ability to produce new red blood cells, compounding the effects of red cell destruction. Parasitic worm infections, particularly hookworm, whipworm, and schistosomiasis, also play a central role in causing anemia in the developing world. Hookworm infection, which occurs through skin contact with contaminated soil, causes blood loss at the site of attachment in the intestines. Over time, this blood loss can lead to chronic iron deficiency, particularly in individuals who already consume diets low in iron. Schistosomiasis, a waterborne parasite, can cause intestinal or urinary tract bleeding, which similarly contributes to iron loss and anemia. Infections such as these are most common in rural areas where open defecation and lack of access to clean water are still major challenges. Additionally, frequent bacterial and viral infections contribute to what is known as anemia of inflammation or anemia of chronic disease. In these cases, the immune system's response to prolonged or repeated infections disrupts iron metabolism and impairs the production of erythropoietin, the hormone responsible for red blood cell production. Conditions such as tuberculosis, HIV/AIDS, and chronic diarrhea can lead to this form of anemia, making treatment more complex than simply addressing nutrient deficiencies. The relationship between infection and anemia is cyclical. Infections contribute to anemia, and anemia weakens the immune system, making individuals more susceptible to further infections. Breaking this cycle requires a comprehensive approach that includes improving sanitation and access to clean water, controlling vector-borne diseases, deworming campaigns, and integrating nutritional support with infection treatment. Public health initiatives that target both the infectious and nutritional causes of anemia are essential to reducing its prevalence and impact in the world's most affected regions. Chapter 3: Epidemiology and Demographics. The epidemiology of nutritional anemia reveals a widespread and persistent public health issue that disproportionately affects populations in developing countries. Understanding who is most affected and where the burden lies is crucial for formulating targeted interventions and allocating resources effectively. Nutritional anemia is not evenly distributed. Rather, it is shaped by a complex interaction of socioeconomic status, geography, gender, age, and existing health infrastructure. Globally, it is estimated that over 2 billion people suffer from anemia, with the majority of cases occurring in low- and middle-income countries. South Asia and Sub-Saharan Africa carry the highest burden, where over 50% of children under the age of 5 and nearly 40% of women of reproductive age are anemic. In contrast, prevalence rates in developed regions are significantly lower, often below 10% in similar demographic groups. This disparity reflects differences in dietary diversity, access to fortified foods, healthcare availability, and control over infectious diseases. Women, particularly those of reproductive age, are among the most vulnerable groups affected by nutritional anemia. Menstruation, pregnancy, and lactation significantly increase the body's demand for iron and other nutrients. In many developing nations, gender inequality further compounds this issue, as women may have limited access to nutrient-rich foods, healthcare, and education. Maternal anemia is closely associated with poor pregnancy outcomes, including preterm birth, low birth weight, and increased risk of maternal mortality, making it a critical concern in reproductive health. Children under 5 are another high-risk group. During early childhood, rapid growth increases nutritional requirements, particularly for iron, folate, and vitamin B12. When these needs are not met, often due to inadequate complementary feeding practices or low-quality diets, anemia can develop quickly. Anemic children are more susceptible to infections, developmental delays, and poor academic performance later in life, perpetuating the cycle of poverty and underachievement. Elderly populations and individuals with chronic illnesses also experience high rates of anemia, although these demographics are often underreported in developing countries. Infections such as HIV, AIDS, and tuberculosis, both prevalent in many low-resource settings, further elevate anemia rates across age groups by increasing nutritional demands and impairing red blood cell production. The demographic data on nutritional anemia underscore the urgent need for targeted strategies that consider age, gender, and regional vulnerabilities. Public health programs must prioritize the most affected groups, women and children, while also addressing systemic issues such as food insecurity, lack of education, and poor healthcare access. Strengthening epidemiological surveillance and data collection in resource-limited settings is equally important for tracking progress and refining interventions over time. Prevalence among vulnerable populations. Nutritional anemia disproportionately affects vulnerable populations, and understanding the specific challenges faced by these groups is essential to addressing the problem effectively. In developing nations, certain populations are particularly at risk of anemia due to a combination of biological, socioeconomic, and environmental factors. Among the most affected are young children, women of reproductive age, and the elderly, as well as individuals living in areas with high disease burdens or poor healthcare access. Children under 5 years of age are one of the most vulnerable groups when it comes to nutritional anemia. During this critical period of growth, the body's demand for iron, folate, and other essential nutrients is elevated. If these needs are not met, the result is an increased risk of anemia, which can have severe consequences for both physical and cognitive development. Anemic children are more likely to experience developmental delays, poor academic performance, and a weakened immune system, making them more susceptible to infections. In many developing nations, where access to a diverse diet is limited, the prevalence of anemia among young children can exceed 50%. Additionally, anemia contributes significantly to infant mortality, as anemic mothers are more likely to have preterm or low birth weight babies, further exacerbating the challenges faced by newborns. Women of reproductive age are another highly vulnerable group, especially during menstruation, pregnancy, and lactation. The increased iron demand during these periods, particularly during pregnancy, places women at a heightened risk of developing anemia, especially in areas where access to iron-rich foods is limited or unaffordable. In pregnancy, anemia is associated with higher rates of maternal morbidity and mortality, as well as adverse outcomes such as preterm birth, low birth weight, and poor fetal development. Globally, anemia affects approximately 40% of pregnant women in low-income regions, a statistic that underscores the urgent need for targeted interventions to improve maternal health. The elderly population, though often overlooked in the context of nutritional anemia, is also at increased risk, particularly those with chronic illnesses such as diabetes, chronic kidney disease, or cancer. These conditions can contribute to anemia through mechanisms such as inflammation, poor nutrient absorption, or blood loss. Additionally, the elderly often experience malnutrition due to factors like decreased appetite, difficulty accessing nutritious foods, and limited mobility. In areas with inadequate healthcare, these factors can lead to a higher prevalence of anemia among older adults, further complicating their health and well-being. In regions with high disease burdens, such as malaria, tuberculosis, and parasitic infections, anemia is even more prevalent. These diseases directly affect red blood cell production or lead to blood loss, further exacerbating existing nutritional deficiencies. As such, addressing anemia among vulnerable populations requires a multifaceted approach that includes not only improving nutrition, but also addressing the underlying health and socioeconomic factors that contribute to the problem. Gender and age-related trends. Gender and age-related trends play a significant role in the prevalence and severity of nutritional anemia, particularly in developing nations. Understanding how anemia affects different genders and age groups is essential for crafting effective interventions and targeting the populations most at risk. In many low-income countries, social, cultural, and economic factors contribute to gender disparities, while age-related physiological differences influence the body's nutritional needs, making certain groups more susceptible to anemia. Women, especially those of reproductive age, are more likely to suffer from anemia compared to men. This is primarily due to the increased nutritional demands associated with menstruation, pregnancy, and lactation. Menstruating women experience regular blood loss, which depletes iron stores, and in the absence of sufficient dietary iron, this can lead to iron deficiency anemia. Pregnancy further exacerbates the risk, as the body requires additional iron to support fetal growth, placenta formation, and the increase in blood volume. Without adequate iron intake, pregnant women are at heightened risk for complications such as preterm birth, low birth weight, and maternal mortality. In many parts of the world, especially where iron-rich foods are limited or inaccessible, anemia during pregnancy is a leading cause of maternal morbidity and mortality. Cultural practices and gender roles also exacerbate anemia in women. In many developing nations, women and girls are often the last to eat, consuming fewer nutrient-dense foods than male family members. Moreover, women in low-income households may lack the resources to purchase adequate amounts of food, particularly meat and other iron-rich foods. This imbalance in food distribution within households contributes to higher rates of anemia among women and girls. While women are generally more affected by anemia than men, age-related trends show that certain groups of children and the elderly are also highly vulnerable. Children under the age of 5 are at a critical stage of development and have high nutritional needs to support growth and cognitive development. In many low-income regions, children's diets are often deficient in essential nutrients like iron, folate, and vitamin B12, leading to a high prevalence of anemia. The impact of anemia on young children can be severe, impairing physical growth, weakening the immune system, and causing developmental delays that affect educational outcomes and long-term well-being. The elderly are also at increased risk for anemia, although the causes are different from those in women and children. In older adults, anemia is often associated with chronic conditions such as chronic kidney disease, cancer, or gastrointestinal disorders, which can impair nutrient absorption or lead to blood loss. Additionally, aging can result in changes to the digestive system, reducing the body's ability to absorb iron and other nutrients, further increasing the risk of anemia. In summary, gender and age-related factors are critical in understanding the epidemiology of nutritional anemia. Addressing these trends requires a holistic approach that considers the specific needs and vulnerabilities of women, children, and the elderly. Gender-sensitive nutritional interventions, alongside strategies aimed at improving access to healthcare and education, are essential for reducing anemia in these high-risk populations. Regional variations in the Third World. The prevalence of nutritional anemia varies significantly across different regions of the developing world, shaped by factors such as geography, socioeconomic conditions, cultural practices, and access to healthcare. In many low-income countries, regional disparities in the rate of anemia reflect differences in agricultural productivity, food security, climate, and public health infrastructure. Understanding these regional variations is essential for developing tailored interventions that address the unique challenges faced by each area. In sub-Saharan Africa, for instance, anemia is a widespread and persistent public health issue, particularly among women and children. High rates of malaria, hookworm infections, and other parasitic diseases contribute to the anemia burden. In addition to the direct effects of these infections on blood cells, the overall health of the population is often compromised by poor sanitation, limited access to clean water, and inadequate healthcare systems. These factors make it challenging to improve nutritional status, as even when iron-rich foods are available, malabsorption due to infections can reduce their effectiveness. Furthermore, many regions in sub-Saharan Africa have limited access to a variety of nutrient-rich foods, with diets predominantly consisting of staples like maize, cassava, and rice, which are low in iron and other essential nutrients. South Asia, another region with a high burden of nutritional anemia, faces its own set of challenges. The combination of poor dietary habits, gender inequalities, and high rates of infectious diseases such as tuberculosis and diarrhea contribute to high anemia prevalence, particularly among women and children. South Asian diets, particularly in rural areas, tend to be heavily plant-based, with limited intake of animal products that provide more bioavailable forms of iron. As in Africa, iron deficiency anemia is common, but other deficiencies, such as those of folate and vitamin B12, also contribute to the problem. In addition, cultural factors such as dietary restrictions and the prioritization of food for male family members often lead to women consuming fewer nutrients, exacerbating the anemia situation. In Latin America, anemia rates are somewhat lower than in sub-Saharan Africa and South Asia, but regional disparities still exist. Rural areas and impoverished communities in countries such as Guatemala, Honduras, and Nicaragua often have higher rates of anemia due to food insecurity, poor access to healthcare, and the prevalence of parasitic infections. In urban areas, although the availability of iron-rich foods may be higher, inequalities in income and education still result in significant gaps in nutrition, leading to anemic conditions among marginalized populations. Southeast Asia also shows considerable regional variation in anemia prevalence. In countries like Indonesia and the Philippines, anemia remains a major health concern, particularly in rural communities where diets lack diversity and infections such as malaria and hookworm are prevalent. In contrast, countries with better healthcare systems, such as Thailand and Malaysia, have lower rates of anemia, though rural areas still experience higher prevalence due to limited access to quality nutrition and healthcare. Ultimately, regional variations in nutritional anemia in the Third World highlight the need for localized strategies that consider the unique economic, environmental, and cultural contexts of each area. Improving access to a diverse diet, enhancing healthcare infrastructure, and implementing targeted public health programs can help reduce the burden of anemia and improve the overall well-being of vulnerable populations. Chapter 4: Socioeconomic and Cultural Determinants. Socioeconomic and cultural factors play a crucial role in the prevalence of nutritional anemia in developing nations. These determinants not only influence access to adequate nutrition, but also shape dietary practices, healthcare utilization, and overall health outcomes. The interplay between income, education, social status, and cultural norms significantly impacts the nutritional status of individuals, particularly in regions where food insecurity, gender inequality, and inadequate healthcare systems are common challenges. One of the most significant socioeconomic factors influencing anemia rates is income. In many low-income regions, individuals and families often face financial constraints that limit their ability to purchase a diverse range of nutritious foods. Diets may be based on a few low-cost staples, such as rice, maize, or cassava, which are calorically sufficient but lack essential micronutrients like iron, folate, and vitamin B12. Limited access to animal products, which are rich sources of bioavailable iron, further exacerbates nutritional deficiencies. This economic constraint is compounded by food insecurity, where access to sufficient, safe, and nutritious food is inconsistent, particularly during periods of drought, conflict, or economic downturns. Poor nutrition during critical periods, such as pregnancy and early childhood, can result in long-term health consequences, perpetuating a cycle of poverty and malnutrition. Education also plays a significant role in the prevention and management of anemia. In regions where literacy rates are low, particularly among women, there is often a lack of knowledge about proper nutrition, the importance of iron-rich foods, and the role of dietary diversity in preventing anemia. Additionally, lower levels of education are often correlated with limited access to health services, making it more difficult for individuals to seek out medical advice or treatment for anemia. Conversely, higher levels of education, particularly for women, have been shown to improve health outcomes, as educated individuals are more likely to make informed decisions about their diets, healthcare, and hygiene practices. Cultural factors also have a profound impact on anemia rates. In many developing countries, cultural practices dictate food consumption patterns, which can either contribute to or mitigate nutritional deficiencies. In some societies, there are taboos or restrictions on certain foods that could provide essential nutrients, such as animal-based products, which are rich in bioavailable iron. For example, religious or cultural beliefs may discourage the consumption of meat or dairy, particularly among women and children, who are at higher risk for developing anemia. Furthermore, traditional gender roles often result in women and girls being the last to eat or receiving less nutritious food than male family members, exacerbating iron deficiency and other forms of malnutrition among females. Social inequalities and gender discrimination further complicate the issue. Women in many developing regions are more likely to be nutritionally disadvantaged, as they often have less access to resources and healthcare. This is particularly true for pregnant women, who face increased nutritional demands but may not have the same access to food or medical care as their male counterparts. Addressing these cultural and socioeconomic determinants requires multifaceted interventions that promote education, gender equality, and economic empowerment, while also improving access to nutritious foods and healthcare services. In conclusion, addressing nutritional anemia in developing nations requires a comprehensive approach that considers both socioeconomic and cultural factors. By improving education, reducing poverty, and challenging harmful cultural norms, it is possible to reduce the burden of anemia and improve the overall health of vulnerable populations. Dietary customs and cultural beliefs. Dietary customs and cultural beliefs play a significant role in shaping the nutritional habits of individuals in developing nations. These cultural practices, often passed down through generations, influence the types of foods consumed, the frequency of meals, and the methods of food preparation. While many of these practices are deeply rooted in tradition and community, they can sometimes contribute to poor nutrition, particularly in the case of anemia, by limiting access to essential nutrients. In many cultures, certain foods are considered more desirable or nutritious than others based on long-standing beliefs about their health benefits. However, these perceptions do not always align with nutritional science. For example, in some regions, animal products like red meat, which are rich in iron, may be reserved for special occasions or not consumed at all due to religious beliefs or social status. Similarly, vegetables and fruits that are high in folate or vitamin C may be overlooked in favor of more starchy foods that are considered staple or filling. These dietary patterns can contribute to deficiencies in essential nutrients like iron, vitamin B12, and folate, which are critical for preventing anemia. Cultural beliefs around food preparation and consumption also affect nutrient absorption. For instance, the practice of soaking or fermenting grains to improve digestibility can reduce the bioavailability of certain nutrients like iron, especially when paired with foods that inhibit iron absorption, such as tea or coffee. Similarly, in some cultures, food taboos during pregnancy or infancy may prevent women from consuming iron-rich foods, exacerbating the risk of anemia for both the mother and the child. Social norms and gender roles also influence the dietary habits that contribute to anemia. In many developing countries, women and children often eat last or receive smaller portions of food, especially in households with limited resources. This can lead to an insufficient intake of iron and other essential nutrients, particularly for pregnant women, who have higher nutritional needs. Gender inequality in food distribution may thus exacerbate the nutritional challenges faced by women and children, making them more vulnerable to anemia. Changing these deeply ingrained cultural practices and beliefs requires a sensitive, community-based approach that respects traditions while promoting nutritional education and awareness. Public health initiatives can work alongside community leaders to encourage dietary modifications that improve nutrition without disregarding cultural values. This approach can help shift attitudes toward more inclusive and balanced diets, ensuring that communities have access to the essential nutrients required to prevent nutritional anemia. In conclusion, dietary customs and cultural beliefs are pivotal in shaping nutritional habits in developing nations. While these traditions are important for social cohesion and identity, they can also limit access to the nutrients necessary for good health. By understanding and working within cultural frameworks, healthcare providers and public health initiatives can address the root causes of anemia and improve nutritional outcomes in these regions. Poverty and food insecurity. Poverty and food insecurity are inextricably linked to the prevalence of nutritional anemia in developing nations. These socioeconomic conditions are primary drivers of inadequate nutrition, which in turn leads to deficiencies in essential vitamins and minerals, particularly iron, folate, and vitamin B12. In many low-income regions, poverty limits access to a varied and nutrient-rich diet, exacerbating the risk of anemia, particularly among vulnerable populations such as women, children, and the elderly. Poverty is a significant barrier to securing an adequate and diverse diet. Families living below the poverty line often prioritize inexpensive, calorie-dense foods that are low in essential micronutrients. These foods, such as white rice, bread, or starchy tubers, may fill the stomach but lack the vitamins and minerals required for maintaining good health. As a result, individuals in these communities are more likely to suffer from nutritional deficiencies, including anemia. When financial resources are scarce, people are forced to make difficult choices about what to eat, and nutrient-rich foods such as meats, legumes, vegetables, and fruits may become unaffordable or inaccessible. This creates a vicious cycle where poor nutrition leads to anemia, which in turn weakens the immune system, making individuals more vulnerable to infections and further hindering their ability to work and earn an income. Food insecurity, which is often a direct consequence of poverty, further exacerbates the problem. In many developing nations, access to sufficient, safe, and nutritious food is inconsistent due to factors such as climate change, economic instability, and inadequate agricultural infrastructure. Droughts, floods, and other natural disasters can disrupt food production and distribution, leading to spikes in food prices and limited availability of nutritious foods. For households already struggling financially, these disruptions make it even more challenging to access the nutrients needed to prevent or treat anemia. Additionally, the seasonal nature of food availability in some regions means that certain months of the year are marked by limited food options, which exacerbates nutritional deficiencies during those times. Food insecurity also has a profound impact on vulnerable populations, particularly women and children. Women, especially those who are pregnant or breastfeeding, have higher nutritional needs and are at increased risk of anemia due to insufficient iron intake. In many poor households, women are the primary caregivers and often eat last after the male members of the family, which means they may receive less food or lower quality food. Children in food-insecure households are similarly at risk, as they may not receive the proper nutrients during critical periods of growth and development. Anemic children face impaired cognitive and physical development, which can affect their school performance and overall health. To combat anemia related to poverty and food insecurity, it is essential to improve access to nutritious food, strengthen food distribution systems, and address the root causes of poverty. Public health interventions such as food fortification, micronutrient supplementation, and education on nutrition can help reduce the burden of anemia in impoverished communities. Additionally, improving economic conditions, increasing access to social safety nets, and investing in agricultural sustainability can help ensure that vulnerable populations are better equipped to meet their nutritional needs. By addressing the socio-economic determinants of anemia, we can break the cycle of poverty and malnutrition that perpetuates the global burden of anemia. Gender inequality and health access. Gender inequality is a significant determinant of health, particularly in developing nations, where societal norms and cultural practices often place women at a disadvantage. This inequality not only restricts access to resources but also limits women's ability to access proper healthcare and nutrition, both of which contribute to the high rates of nutritional anemia among females. The intersection of gender inequality and limited health access creates a vicious cycle, where women are more likely to experience malnutrition and anemia, which in turn affects their health and well-being. In many low-income countries, women face structural barriers to healthcare access, including limited financial resources, cultural restrictions, and a lack of education. These barriers often prevent women from seeking or receiving appropriate care during critical times such as pregnancy, postpartum, and menopause, when their nutritional needs are heightened. For instance, pregnant women require increased iron to support fetal development and compensate for the blood loss during childbirth. However, in many regions, women are not only unable to access iron-rich foods, but also face difficulties in obtaining adequate maternal healthcare services. This is especially true in rural or remote areas, where healthcare facilities may be distant, and healthcare workers may be insufficiently trained or equipped to address the nutritional needs of women. Cultural norms and gender roles further exacerbate the situation. In many societies, women are often the last to eat, consuming what is left over after male family members have had their fill. This food distribution inequality, combined with the often lower status and decision-making power of women within households, leads to insufficient intake of essential nutrients like iron, folate, and vitamin B12. Women in these settings may also be subject to dietary restrictions based on cultural or religious beliefs, such as limiting the consumption of meat, dairy, or other iron-rich foods. These dietary practices place women at greater risk of anemia, especially when combined with poverty and food insecurity. Moreover, the lack of education about nutrition and anemia is another consequence of gender inequality. Women who are less educated about the causes and prevention of anemia are less likely to adopt behaviors that could prevent it, such as consuming iron-rich foods or seeking medical advice. In many communities, education for girls is often less prioritized than for boys, perpetuating a cycle of poor health outcomes for women and their children. In conclusion, addressing gender inequality is crucial in reducing the prevalence of nutritional anemia in developing nations. Empowering women through education, improving access to healthcare, and ensuring that women have equal access to nutritious food are key strategies in breaking the cycle of anemia and improving overall health outcomes. Only by addressing the social and gender-based factors that limit women's health access can we begin to tackle the root causes of anemia in these vulnerable populations. Chapter 5: Health Consequences and Complications. Nutritional anemia is not just a condition of insufficient red blood cells or hemoglobin in the body. It carries significant health consequences that affect various organ systems and can lead to a range of complications, particularly when left untreated. In developing nations where access to healthcare and proper nutrition is often limited, the effects of anemia are even more pronounced, leading to severe long-term health issues. These consequences extend beyond the individual, impacting families, communities, and entire healthcare systems. One of the most direct health consequences of nutritional anemia is its impact on the immune system. Iron, vitamin B12, and folate, all essential nutrients for red blood cell production, also play vital roles in immune function. A deficiency in these nutrients weakens the body's ability to fight infections, making anemic individuals more vulnerable to illnesses such as pneumonia, tuberculosis, and malaria. In children, this weakened immune response leads to higher rates of childhood infections, contributing to the cycle of poor health and underdevelopment. Furthermore, anemia can delay recovery from illness, as the body lacks the necessary resources to repair and regenerate tissues. In addition to immune system dysfunction, anemia can severely affect cognitive and physical development, especially in young children and pregnant women. For children, anemia can impair brain development, leading to learning difficulties, poor academic performance, and behavioral issues. In severe cases, it can result in long-term cognitive deficits that affect educational outcomes and future opportunities. In pregnant women, anemia increases the risk of maternal and fetal complications, including preterm labor, low birth weight, and even maternal death. Anemia also increases the likelihood of postpartum hemorrhage, a leading cause of maternal mortality in developing countries. Another significant complication of anemia is its impact on cardiovascular health. The heart works harder to pump oxygenated blood to the body's tissues when hemoglobin levels are low. Over time, this increased strain can lead to cardiovascular complications, including heart failure, especially in individuals with chronic anemia. Anemia has been linked to a higher risk of developing both hypertension and heart disease, further complicating the health profile of affected individuals. The economic and social impact of anemia is also substantial. Anemic individuals, particularly those with severe or long-term anemia, may experience fatigue, weakness, and reduced productivity, which affects their ability to work or contribute to their household income. In low-income countries, this reduced productivity can hinder overall economic growth, as a significant portion of the population is unable to fully participate in the workforce due to the debilitating effects of anemia. In conclusion, the health consequences of nutritional anemia are far-reaching, affecting individuals' physical, cognitive, and emotional well-being. Addressing anemia in developing nations is not just a matter of improving individual health, but also a critical component of enhancing social and economic development. Reducing the burden of anemia can lead to healthier, more productive populations, capable of breaking the cycle of poverty and malnutrition. Maternal and child health impacts. Nutritional anemia has profound impacts on maternal and child health, with severe consequences for both mothers and their offspring, particularly in developing nations. In these regions, where access to healthcare and proper nutrition is often limited, anemia exacerbates existing health challenges and contributes to high rates of maternal and infant morbidity and mortality. The intergenerational effects of anemia are particularly troubling, as malnourished mothers are more likely to give birth to undernourished children, creating a cycle of poor health outcomes that persist across generations. For pregnant women, anemia significantly increases the risk of complications during pregnancy, labor, and delivery. During pregnancy, the body requires additional iron to support the growing fetus and placenta, as well as the increased blood volume. When iron intake is insufficient, maternal anemia can lead to preterm labor, low birth weight, and stillbirth. The risks are heightened for women who are already malnourished or who face socioeconomic barriers to accessing proper health care. Anemic women are also more likely to experience postpartum hemorrhage, a leading cause of maternal death in developing countries. Postpartum anemia can delay recovery and complicate breastfeeding, further compromising the health of both mother and child. The effects of anemia on maternal health extend to long-term consequences as well. Anemic women often experience fatigue, weakness, and reduced immune function, which can hinder their ability to care for their newborns and participate in daily activities. In communities with limited healthcare resources, these ongoing health challenges can reduce a mother's quality of life and her ability to provide the necessary care for her family, affecting her long-term well-being and economic productivity. For infants and young children, the effects of anemia are equally concerning. Anemia in early childhood can have significant developmental consequences, particularly in terms of cognitive and physical growth. Children with anemia often experience delayed motor skills, difficulty concentrating, and reduced academic performance. Severe or chronic anemia can impair brain development, leading to long-term learning disabilities and lower educational attainment. In many cases, anemia in infancy and early childhood can increase the risk of other infections, as the immune system is weakened by nutritional deficiencies. Moreover, maternal anemia contributes to a higher incidence of low birth weight and preterm births, both of which are linked to higher rates of neonatal morbidity and mortality. Newborns born to anemic mothers are more likely to face developmental delays and a greater susceptibility to infections. Without proper nutrition and medical intervention, these children are more likely to experience poor health outcomes in early childhood and beyond. In conclusion, the impacts of nutritional anemia on maternal and child health are far-reaching and multifaceted. Addressing anemia in women of reproductive age and young children is critical for improving maternal and child health outcomes. Comprehensive strategies, including better access to prenatal care, nutrition education, iron supplementation, and improved food security, are essential to reducing the health burden of anemia and breaking the cycle of poor maternal and child health. Cognitive and physical developmental issues. Nutritional anemia, particularly in its severe or chronic form, has profound effects on both cognitive and physical development, especially in children. In developing nations, where access to adequate nutrition is often limited, the prevalence of anemia in early childhood is a significant concern, as it can lead to long-term developmental issues that affect both brain function and physical growth. The detrimental effects of anemia on children's cognitive and physical development can hinder their ability to succeed academically and achieve their full potential in life. Anemia, particularly iron deficiency, is closely linked to impaired cognitive development in children. Iron is a crucial component of hemoglobin and plays an essential role in oxygen transport to the brain. Inadequate iron levels during critical stages of brain development, such as early childhood, can lead to deficits in memory, learning, and concentration. Children with anemia often struggle with attention span, language development, and problem-solving skills. Studies have shown that anemic children tend to score lower on standardized cognitive tests and may exhibit behavioral issues, such as irritability or poor social interactions, which further complicate their educational experience. This cognitive impairment can persist into adolescence and adulthood, potentially reducing their ability to complete education, attain gainful employment, and contribute productively to society. The physical consequences of anemia are also significant. Children with severe or chronic anemia often experience stunted growth, as the body prioritizes the limited nutrients available for survival over development. These children may have delayed motor skills, weakened muscles, and decreased stamina, which can affect their ability to engage in physical activities and participate fully in daily life. Anemic children are more prone to fatigue, which limits their participation in school, play, and social interactions, further contributing to physical and cognitive delays. In addition to physical growth delays, anemia also weakens the immune system, making children more vulnerable to infections and illnesses, which can further impede physical development. Frequent illness in anemic children can result in cycles of malnutrition and underdevelopment, as they may not receive adequate nourishment during periods of illness or recovery. Addressing anemia in early childhood is critical for preventing these cognitive and physical developmental issues. Adequate nutrition, including iron supplementation and a balanced diet rich in essential vitamins and minerals, is vital for supporting optimal brain and physical development. Interventions such as early detection, health education, and improved access to nutritious food are essential to break the cycle of anemia and promote better health outcomes for children. In conclusion, anemia has far-reaching effects on both cognitive and physical development in children. By addressing nutritional deficiencies early and ensuring that children have access to the nutrients they need, it is possible to prevent many of the developmental issues associated with anemia, ensuring healthier and more productive futures for children in developing nations. Burden on healthcare systems. Nutritional anemia places a significant strain on healthcare systems, particularly in developing nations where resources are already stretched thin. The widespread prevalence of anemia across populations, especially in children, women of reproductive age, and the elderly, leads to an increased burden on hospitals, clinics, and healthcare workers. Addressing anemia requires extensive healthcare infrastructure, including screening, diagnosis, treatment, and long-term management, which can overwhelm already limited health resources. One of the primary ways anemia affects healthcare systems is through the high volume of cases requiring medical attention. Anemia is often a chronic condition, meaning that individuals with moderate or severe anemia may require ongoing care, including iron supplementation or blood transfusions. This continuous demand for healthcare services can lead to overcrowded healthcare facilities, longer wait times for patients, and a higher workload for healthcare professionals. As anemia is commonly associated with other health complications, such as infections, malnutrition, and developmental delays, the treatment of anemia often involves multiple health interventions, further increasing the burden on healthcare providers. Moreover, anemia contributes to higher rates of hospitalization, particularly among vulnerable groups such as pregnant women and children. Pregnant women with anemia are at increased risk of complications such as preterm birth, postpartum hemorrhage, and maternal death. The need for emergency care and the management of these complications strains healthcare systems that are often already under-resourced. For children, anemia can lead to frequent infections, stunted growth, and cognitive impairment, requiring long-term medical care and monitoring. These ongoing health issues result in higher healthcare costs and the allocation of limited funds to manage these cases, diverting resources away from other essential services. The financial burden of anemia also extends to healthcare systems in the form of increased treatment costs. The long-term management of anemia, including the provision of iron supplements, blood transfusions, and other interventions, incurs significant healthcare expenses. In countries with limited budgets, these costs can be prohibitive, especially when anemia is widespread and untreated. Additionally, addressing the root causes of anemia, such as poor nutrition and food insecurity, requires extensive public health interventions, which demand both time and financial resources. The impact of anemia on healthcare systems is compounded by a lack of education and awareness about the condition. In many developing nations, individuals may not recognize the symptoms of anemia, leading to delayed diagnosis and treatment. This lack of awareness among both the public and healthcare providers can lead to preventable complications, further increasing the strain on healthcare facilities. In conclusion, nutritional anemia imposes a heavy burden on healthcare systems in developing nations. The prevalence of anemia leads to increased demand for medical services, higher healthcare costs, and the allocation of limited resources to manage its effects. Addressing anemia through prevention, early detection, and improved healthcare infrastructure is critical to alleviating this burden and improving overall health outcomes in these regions. Chapter 6: Diagnostic Challenges and Approaches. The diagnosis of nutritional anemia in developing nations presents numerous challenges, primarily due to limited access to healthcare resources, a lack of diagnostic infrastructure, and the complexity of identifying the condition in its early stages. Given that anemia can result from a variety of causes, including iron, vitamin B12, and folate deficiencies, infections, and other underlying health conditions, diagnosing it requires comprehensive clinical evaluation, laboratory tests, and a detailed understanding of local nutritional patterns and health practices. One of the key challenges in diagnosing nutritional anemia is the lack of accessible healthcare facilities and diagnostic tools. In many low-income regions, medical infrastructure is underdeveloped, and healthcare workers often lack access to the necessary equipment to carry out blood tests or advanced diagnostics. The absence of basic diagnostic tools like hemoglobin meters, complete blood count, CBC tests, and iron studies often delays the detection of anemia, leading to missed or incorrect diagnoses. Without these basic tools, healthcare providers may rely on clinical signs and symptoms such as fatigue, pale skin, and weakness, which are often not specific enough to differentiate anemia from other conditions, further complicating diagnosis. Another challenge is the overlap of anemia with other common diseases in developing countries, such as malaria, tuberculosis, and hookworm infections. These conditions can exacerbate the symptoms of anemia, making it difficult to determine whether anemia is the primary issue or a secondary condition resulting from an infection. For example, malaria-induced anemia and iron deficiency anemia may present with similar symptoms, but their underlying causes require different treatment approaches. As such, accurate diagnosis necessitates distinguishing between these conditions, which can be difficult in resource-poor settings without advanced laboratory capabilities. Furthermore, the complexity of anemia itself can be a diagnostic challenge. Nutritional anemia is often multifactorial, meaning it can result from multiple deficiencies in a population that faces chronic food insecurity or limited access to a variety of nutrients. In many cases, individuals may experience a combination of iron, folate, and vitamin B12 deficiencies, which can further complicate diagnosis and treatment. Therefore, healthcare providers need to consider the individual's overall nutritional status and potential coexisting conditions when diagnosing and planning treatment. Approaches to improving diagnosis include enhancing healthcare infrastructure, increasing the availability of essential diagnostic tools, and training healthcare workers in the early identification of anemia and its potential causes. Implementing point-of-care diagnostic tests, such as portable hemoglobin meters and rapid diagnostic tests for common infectious diseases, could significantly improve diagnostic accuracy. Additionally, greater community awareness about the symptoms and risks of nutritional anemia, coupled with educational programs for healthcare providers, would help facilitate early detection and prompt intervention. In conclusion, diagnosing nutritional anemia in developing nations requires overcoming significant challenges related to infrastructure, diagnostic tools, and the complexity of the condition itself. Strengthening healthcare systems, improving access to diagnostic tools, and enhancing the capacity of healthcare workers are critical steps in ensuring that anemia is accurately diagnosed and effectively treated. Clinical and laboratory diagnostic methods. The diagnosis of nutritional anemia in developing nations often involves a combination of clinical evaluation and laboratory tests. Early identification is crucial to preventing long-term health consequences, yet the availability of diagnostic methods can be limited in resource-constrained settings. Nevertheless, both clinical and laboratory diagnostic methods are essential for accurately diagnosing anemia, determining its severity, and identifying its underlying causes, which is important for tailoring appropriate treatment strategies. Clinically, the diagnosis of anemia begins with a detailed patient history, including information about dietary habits, socioeconomic status, and any underlying medical conditions that might contribute to anemia. Physical examination plays an essential role in identifying signs of anemia, such as pallor, pale skin and mucous membranes, fatigue, weakness, dizziness, and tachycardia. In children, signs of developmental delays and poor growth may also be indicators of anemia. While these clinical observations can provide important clues, they are not definitive, as symptoms can overlap with other conditions. Therefore, laboratory confirmation is needed for an accurate diagnosis. The most commonly used laboratory test for diagnosing anemia is the hemoglobin level measurement, typically through a blood sample. A hemoglobin concentration below a specific threshold, usually 11 to 13 grams per deciliter for children and non-pregnant women, and 10.5 grams per deciliter for pregnant women, indicates anemia. However, this test only identifies the presence of anemia and does not provide information about its underlying cause. To determine the specific type of anemia, further tests are needed. Iron deficiency anemia, the most prevalent form of nutritional anemia, can be diagnosed through tests such as serum ferritin, transferrin saturation, and serum iron levels. Low levels of ferritin indicate depleted iron stores, while low transferrin saturation and serum iron levels confirm the deficiency. However, serum ferritin can be elevated in the presence of inflammation or infection, which can complicate the interpretation of results. For vitamin B12 and folate deficiencies, blood tests measuring serum levels of these vitamins are useful. A low serum vitamin B12 or folate level, combined with clinical symptoms and a history of poor dietary intake, can confirm the diagnosis. Additionally, a high mean corpuscular volume (MCV) in a complete blood count (CBC) can suggest megaloblastic anemia due to B12 or folate deficiency. In regions where laboratory resources are scarce, point-of-care testing, such as portable hemoglobin meters and rapid diagnostic tests for common infectious diseases, can help improve diagnosis. These methods offer quicker results, although they are not as comprehensive as laboratory-based tests. In conclusion, clinical evaluation, combined with laboratory diagnostic methods, is critical for the accurate diagnosis of nutritional anemia. In resource-limited settings, improving access to diagnostic tools and training healthcare providers to interpret results effectively can help reduce the burden of anemia and its associated health complications. Barriers to accurate diagnosis in low-resource settings. Accurately diagnosing nutritional anemia in low-resource settings presents numerous challenges, many of which are tied to limitations in infrastructure, access to medical supplies, and insufficient healthcare personnel. These barriers can delay diagnosis, leading to underdiagnosis or misdiagnosis, which exacerbates the health impact of anemia and its associated complications in vulnerable populations. One of the most significant barriers to accurate diagnosis is the lack of diagnostic infrastructure. In many low-resource settings, healthcare facilities may lack the necessary equipment to perform basic diagnostic tests, such as complete blood counts, CBC, serum iron tests, or vitamin levels. Without access to these essential tools, healthcare providers are left to rely on clinical symptoms alone, which can often be nonspecific and misleading. Fatigue, pallor, and weakness, for example, are common symptoms of anemia, but can also be attributed to other conditions like infections or chronic diseases, leading to an inaccurate diagnosis. The scarcity of skilled healthcare professionals is another critical barrier. In many developing countries, there is a shortage of trained medical personnel capable of identifying the signs of nutritional anemia or interpreting test results. In rural or underserved areas where healthcare services are already limited, the challenge is compounded by the lack of specialized training in diagnosing and treating anemia. Furthermore, healthcare workers may not be familiar with the local prevalence of certain types of anemia, such as vitamin B12 or folate deficiency, which are often linked to dietary patterns in specific regions. In addition to these technical challenges, financial constraints are a major obstacle to accurate diagnosis. Diagnostic tests, such as blood work or specialized screenings, often come with a high cost, making them inaccessible for many individuals in low-income areas. Many families are unable to afford the tests required for a definitive diagnosis, and in some cases, patients may not seek medical attention due to the associated costs. This often leads to a reliance on symptom-based treatments, which can fail to address the root cause of the anemia. Moreover, the lack of awareness about anemia and its nutritional causes further complicates the diagnostic process. In many communities, anemia is seen as a normal or inevitable part of life, particularly in children and pregnant women. This cultural normalization of anemia often results in delayed healthcare seeking, as individuals may not recognize the severity of their condition or understand the importance of early intervention. Finally, logistical challenges, such as the poor transportation infrastructure in rural areas and the absence of reliable supply chains for medical equipment and medications, further hinder diagnostic efforts. In some regions, the time it takes for diagnostic results to be delivered or the unavailability of treatments can discourage timely diagnosis and intervention. In conclusion, the barriers to accurate diagnosis of nutritional anemia in low-resource settings are multifaceted, involving infrastructural deficiencies, a lack of skilled personnel, financial constraints, cultural factors, and logistical challenges. Overcoming these barriers requires a comprehensive approach, including increasing access to diagnostic tools, training healthcare workers, and raising community awareness about the importance of early detection and treatment of anemia. Emerging technologies and innovations. The advancement of emerging technologies offers promising solutions to the challenges faced in diagnosing and managing nutritional anemia in low-resource settings. Innovations in diagnostic tools, treatment methods, and healthcare delivery systems have the potential to overcome many of the barriers that currently limit the effectiveness of anemia control programs in developing nations. These technologies not only improve the accuracy of diagnosis, but also enhance accessibility and affordability, bringing significant improvements to public health. One key innovation is the development of point-of-care diagnostic tools. Traditional diagnostic methods, such as blood tests, often require laboratory facilities that are unavailable in rural or resource-limited areas. However, portable and affordable diagnostic devices, such as handheld hemoglobin meters, have become more widely accessible. These devices enable healthcare workers to quickly measure hemoglobin levels and diagnose anemia at the community level, reducing the need for patients to travel long distances to access healthcare facilities. This makes the process of diagnosis faster and more efficient, facilitating early detection and intervention. In addition to point-of-care diagnostics, the use of mobile health (mHealth) technologies is revolutionizing the management of anemia. Mobile apps that allow patients and healthcare providers to monitor nutritional intake, track iron supplementation, and receive reminders for regular checkups are becoming increasingly popular. Health platforms also enable healthcare workers to access educational resources and receive telemedicine consultations, which is especially valuable in regions where there is a shortage of trained medical professionals. By leveraging mobile phones, these technologies provide scalable solutions to anemia management in remote areas. Telemedicine is another emerging innovation that can bridge the gap in healthcare access. Through telehealth platforms, patients can consult with specialists remotely, which is particularly beneficial for individuals living in isolated areas. Remote consultations can help identify underlying causes of anemia, offer advice on dietary changes, and monitor progress, reducing the need for in-person visits to distant healthcare facilities. This not only saves time and money for patients, but also alleviates the burden on overworked healthcare systems. Furthermore, advancements in nutraceuticals and iron supplementation therapies have enhanced the effectiveness of anemia treatments. New forms of iron supplements, such as micronized iron or slow-release formulations, are being developed to improve absorption rates and reduce common side effects like gastrointestinal discomfort. Additionally, fortified foods are being engineered to include essential nutrients, such as iron, vitamin B12, and folate, in a more bioavailable form, providing an alternative method for improving nutritional intake in populations at risk for anemia. Finally, research into genetic and molecular diagnostics holds the potential for more precise and individualized treatment plans. Emerging technologies like next-generation sequencing could help identify genetic predispositions to anemia, leading to more targeted interventions based on an individual's specific needs and deficiencies. In conclusion, emerging technologies and innovations are playing an increasingly vital role in the fight against nutritional anemia. From point-of-care diagnostics to mobile health platforms, these advancements are enhancing the accessibility, affordability, and effectiveness of anemia diagnosis and treatment in developing nations. As these technologies continue to evolve, they offer significant promise for improving health outcomes and addressing the global burden of nutritional anemia. Chapter 7: Intervention Strategies and Public Health Policies. Addressing nutritional anemia in developing nations requires a multifaceted approach that combines targeted intervention strategies with effective public health policies. These interventions must be tailored to the specific needs of vulnerable populations and the unique challenges faced in low-resource settings. By implementing comprehensive strategies that include education, supplementation, food fortification, and healthcare system strengthening, public health efforts can significantly reduce the burden of anemia and improve overall health outcomes. One of the most effective intervention strategies is iron and micronutrient supplementation. Providing iron supplements, often in combination with folic acid or vitamin B12, has been a cornerstone of anemia prevention and treatment. These interventions are particularly beneficial for high-risk groups such as pregnant women, young children, and individuals with known deficiencies. In some regions, community-based distribution programs and school health programs are used to ensure that these supplements reach the most vulnerable populations. These programs often include education on the importance of taking the supplements regularly and the potential side effects, which can help improve adherence and effectiveness. In addition to supplementation, food fortification plays a crucial role in addressing the underlying causes of nutritional anemia. Fortifying staple foods such as flour, rice, and salt with iron, folic acid, and other essential nutrients can provide a cost-effective and sustainable solution to improve population-wide nutrition. Fortification efforts can be particularly successful in areas with limited access to diverse foods, ensuring that all individuals, regardless of socioeconomic status, receive adequate nutrition. These initiatives often require collaboration between governments, international organizations, and the private sector to ensure that the fortified products are affordable, accessible, and culturally acceptable. Public health education campaigns are another vital strategy in combating nutritional anemia. Educating communities about the importance of balanced diets, the role of specific nutrients in preventing anemia, and the consequences of poor nutrition can help change dietary habits and promote healthier food choices. These campaigns can also address cultural beliefs and practices that may contribute to anemia, such as food taboos or gender-based inequities in food distribution. By raising awareness and providing practical guidance on how to improve dietary habits, these programs can empower individuals and communities to take control of their health. Strengthening healthcare systems is also essential for the successful prevention and treatment of anemia. In many low-resource settings, healthcare systems are understaffed and lack the infrastructure to diagnose and treat anemia effectively. Investing in healthcare worker training, improving diagnostic capabilities, and ensuring access to essential medicines are critical steps in building a more resilient healthcare system that can better address anemia. Furthermore, integrating anemia prevention and treatment into broader health programs, such as maternal and child health initiatives, can improve efficiency and reach. In conclusion, addressing nutritional anemia in developing nations requires a comprehensive approach that combines supplementation, food fortification, education, and healthcare system strengthening. By implementing evidence-based interventions and public health policies, countries can make significant progress in reducing the prevalence of anemia and improving the health and well-being of their populations. Food fortification and supplementation programs. Food fortification and supplementation programs are crucial interventions for combating nutritional anemia in developing nations. These programs address micronutrient deficiencies that are often the root causes of anemia, particularly in populations with limited access to diverse, nutrient-rich foods. Through fortification, essential nutrients like iron, folic acid, and vitamin B12 are added to staple foods, while supplementation provides targeted nutrients to at-risk groups. Both strategies are effective tools in the fight against anemia, providing long-term solutions that can be integrated into public health systems. Food fortification is one of the most cost-effective strategies to improve public health nutrition. By adding essential nutrients to commonly consumed foods, such as wheat flour, rice, salt, and oils, fortification ensures that entire populations, including those in rural and hard-to-reach areas, have access to the nutrients needed to prevent anemia. Iron fortification is particularly beneficial in addressing iron deficiency anemia, which is the most common type of nutritional anemia worldwide. In many countries, iron is added to salt or flour, which are dietary staples, ensuring widespread coverage. When done properly, food fortification reaches individuals who may not have access to supplements, or who have limited knowledge of the importance of a balanced diet. Supplementation programs, on the other hand, target specific groups that are most at risk for anemia, including pregnant women, young children, and people with existing health conditions. Iron and folic acid supplements are typically distributed through healthcare clinics or community health programs. These programs are often implemented in conjunction with antenatal care, ensuring that pregnant women receive the necessary nutrients to prevent anemia and support healthy fetal development. Supplementation is also crucial for young children, who are highly vulnerable to the effects of anemia on their cognitive and physical development. Providing these groups with the necessary micronutrients helps to reduce the incidence of anemia and its associated health impacts. While food fortification and supplementation programs have proven effective in many settings, there are challenges in ensuring their sustainability and effectiveness. One challenge is ensuring proper adherence to supplementation regimens, as people may forget to take their supplements or experience side effects, such as gastrointestinal discomfort. Additionally, fortification programs must be carefully monitored to ensure that the added nutrients are absorbed efficiently and do not interact negatively with other dietary components. In conclusion, food fortification and supplementation programs are vital components of public health strategies to combat nutritional anemia in developing nations. By providing a reliable source of essential nutrients, these programs help improve the health of vulnerable populations and reduce the burden of anemia. With careful planning, monitoring, and community engagement, these programs can contribute to long-term improvements in nutrition and overall health outcomes. Community-based nutrition education. Community-based nutrition education plays a pivotal role in addressing nutritional anemia, especially in developing nations where limited health infrastructure and cultural practices often hinder effective intervention. These education programs aim to raise awareness, promote healthy dietary behaviors, and empower individuals and communities with the knowledge needed to prevent and manage anemia. By grounding education efforts within communities, such initiatives foster greater engagement, cultural relevance, and long-term behavioral change. In many regions affected by nutritional anemia, lack of knowledge about proper nutrition is a significant barrier. Community-based programs bridge this gap by delivering targeted education on the importance of iron-rich foods, the role of vitamin B12 and folate, and the impact of dietary habits on anemia risk. These programs often involve local health workers, teachers, and community leaders who are trusted figures and can communicate effectively in local languages and cultural contexts. This approach not only improves comprehension, but also increases the likelihood that messages will be accepted and acted upon. One of the strengths of community-based education is its ability to address local dietary patterns and food availability. Educational sessions are often tailored to incorporate foods that are culturally acceptable and locally accessible. For example, rather than promoting expensive supplements or unfamiliar foods, community nutrition workers might highlight affordable iron-rich options such as dark leafy greens, legumes, or fortified staples available in local markets. By demonstrating how to prepare these foods in ways that preserve nutrient content and enhance absorption, such as combining iron-rich foods with vitamin C sources, educators help participants apply the information in practical ways. These programs also serve as a platform for dispelling myths and overcoming harmful cultural beliefs that contribute to poor nutrition. In some communities, taboos restrict women or children from eating certain nutritious foods. Community discussions and participatory learning activities help challenge these norms and encourage more equitable food distribution within households. Involving men and other family members in these sessions can further strengthen community-wide support for healthier practices. Community-based education initiatives are most effective when they are integrated with other health services, such as maternal and child health programs, school feeding schemes, or supplementation efforts. This integrated approach reinforces key messages through multiple channels and ensures that knowledge is accompanied by access to nutritional support. Periodic follow-ups, support groups, and peer educators also help sustain interest and accountability. Ultimately, community-based nutrition education is a low-cost, high-impact strategy that fosters local ownership of health issues and builds a foundation for lasting improvements in nutrition. By empowering communities with the knowledge and tools to prevent nutritional anemia, these programs contribute significantly to broader public health goals and social development. Government and NGO-led initiatives. Government and NGO-led initiatives are central to the fight against nutritional anemia in developing nations. These coordinated efforts provide essential resources, policy direction, and grassroots engagement to reduce the burden of anemia across various population groups. Governments typically set national nutrition agendas and allocate funding, while non-governmental organizations, NGOs, often operate on the ground, delivering programs and services directly to communities. Together, these sectors complement each other's strengths to create scalable, sustainable solutions. At the governmental level, many countries have established national nutrition strategies that prioritize the prevention and treatment of anemia. These policies often include nationwide iron and folic acid supplementation programs, food fortification regulations, and public awareness campaigns. Ministries of Health, Education, and Agriculture collaborate to integrate nutrition objectives into broader development plans. For example, school-based nutrition programs, maternal health services, and social protection schemes are often aligned with anemia reduction goals. Governments also play a vital role in monitoring and evaluating progress, enabling evidence-based adjustments to policies and interventions. NGOs, both international and local, are instrumental in delivering community-level programs and piloting innovative approaches. They often fill gaps in service delivery where government capacity is limited, especially in rural or underserved regions. NGOs conduct nutrition screenings, distribute supplements, offer health education, and build local capacity through training and infrastructure development. They also serve as important advocates, using research and field experiences to influence policy decisions and promote increased funding for nutrition initiatives. A successful example of collaboration is the implementation of iron fortification in staple foods, such as wheat or rice, which often requires joint efforts between government regulators and NGOs that work with food producers and local communities. NGOs may assist in educating the public about fortified foods and tracking consumption patterns, while governments ensure quality standards and compliance across industries. These partnerships enable broad outreach while maintaining accountability and consistency. Emergency contexts, such as humanitarian crises or conflict zones, also highlight the importance of government-NGO cooperation. NGOs are frequently first responders in these situations, distributing micronutrient supplements and fortified foods to displaced or malnourished populations. Governments, in turn, can support these efforts by easing logistics, customs regulations, and providing security or coordination through national disaster response agencies. Ultimately, the synergy between governments and NGOs creates a powerful framework for tackling nutritional anemia. By combining policy authority with operational agility, these initiatives not only treat immediate deficiencies but also lay the groundwork for long-term systemic change. Ensuring continued collaboration, funding, and data sharing between these sectors is essential to building resilient health systems and healthier populations. Chapter 8: Case Studies and Field Insights. Understanding nutritional anemia in developing nations requires more than theoretical knowledge. It demands insights from real-world experiences. Chapter 8 delves into case studies and field observations that offer a practical perspective on how interventions have been implemented, the challenges encountered, and the successes achieved. These examples provide a grounded understanding of how policy, cultural dynamics, infrastructure, and community participation shape outcomes in diverse settings. One notable case comes from Bangladesh, where a community-based approach significantly reduced anemia among women of reproductive age. In partnership with local health workers, NGOs launched a campaign combining iron folic acid supplementation with culturally tailored nutrition education. The program not only distributed supplements through maternal health clinics, but also conducted household visits and community meetings to educate women and their families on dietary practices. This dual approach resulted in improved adherence to supplementation and an increase in the consumption of iron-rich foods, leading to a measurable decline in anemia prevalence. In contrast, a case study from parts of sub-Saharan Africa highlights the difficulties of implementing anemia interventions in regions affected by conflict and displacement. In South Sudan, for instance, high rates of anemia persist due to limited healthcare access, food insecurity, and ongoing instability. Efforts by international humanitarian organizations have included emergency distribution of fortified foods and mobile health clinics, yet long-term impact remains constrained by logistical and security challenges. This underscores the need for flexible, adaptive strategies in fragile contexts. India presents a complex case where large-scale governmental programs, like the Anemia Mukt Bharat initiative, aim to address anemia nationwide through a multi-pronged strategy. Despite robust policy frameworks, field data reveals that implementation varies significantly across states, influenced by local governance, resource availability, and community engagement. In states where local leaders champion the program and invest in training frontline workers, notable progress has been made. Conversely, regions with weaker infrastructure continue to struggle with coverage and monitoring. Field insights also highlight the critical role of cultural beliefs and practices in shaping outcomes. In rural Ethiopia, for example, dietary taboos and food-sharing traditions have hindered women's ability to access sufficient iron. Programs that engaged religious leaders and elders in education campaigns proved more effective in shifting these norms, demonstrating the importance of culturally informed strategies. These case studies emphasize that while technical solutions are essential, local context and community involvement are equally crucial. Learning from successes and setbacks in the field, not only enhances program design, but also fosters innovation and resilience in tackling nutritional anemia. Successful intervention models, e.g., India, Sub-Saharan Africa. Several countries in developing regions have successfully implemented intervention models that have made significant strides in combating nutritional anemia. India and Sub-Saharan Africa offer notable examples where targeted efforts, integrating multiple approaches, have contributed to improving public health outcomes and reducing the prevalence of anemia. In India, the National Iron Plus initiative represents one of the country's most ambitious attempts to address iron deficiency anemia, particularly among children and pregnant women. Through the distribution of iron and folic acid supplements, along with food fortification strategies, the initiative has been able to reach millions. One of the key successes has been the integration of iron supplementation into existing maternal and child health programs, which has allowed for wide-scale implementation and significant impact. The Indian government has also partnered with the World Health Organization (WHO) and UNICEF to expand these programs, incorporating community health workers and local governments to ensure that iron-rich foods and supplements reach remote areas. The focus on food fortification, particularly in wheat flour and salt, has provided an ongoing, sustainable method of addressing iron deficiencies. Another critical factor in India's success has been its school-based interventions. The midday meal scheme, which provides hot, nutritious meals to children, has been instrumental in addressing both nutritional deficiencies and anemia in children. By including iron-rich foods in these meals and ensuring regular deworming, the program has significantly reduced anemia rates in school-age children. With the backing of local authorities and schools, the program has successfully engaged families in rural areas, promoting better dietary practices and improving child health outcomes. Sub-Saharan Africa has also witnessed successful models of anemia intervention, particularly through multi-pronged strategies. In countries like Kenya and Tanzania, the combination of iron supplementation, deworming, and public health education has made considerable progress. For example, the Kenya school-based deworming program, which also includes iron supplementation, has helped reduce anemia in school-aged children by addressing both parasitic infections and nutritional deficiencies. This model is built on the successful integration of health programs within the educational system, allowing for easy access and high participation rates among children. In addition to school-based programs, Sub-Saharan Africa has also embraced community health worker initiatives that focus on education, distribution of supplements, and nutritional guidance. These workers, often from within the communities they serve, bridge the gap between remote populations and healthcare systems. Their presence has been crucial in raising awareness, ensuring adherence to treatment, and offering culturally relevant dietary advice. Both India and Sub-Saharan Africa provide evidence that when anemia interventions are holistic, community-driven, and integrated into existing health and education systems, they can lead to lasting improvements in public health, reducing the burden of anemia and its associated complications. Lessons learned from multinational programs. Multinational programs aimed at addressing nutritional anemia in developing nations have provided invaluable lessons that continue to inform global health strategies. These large-scale initiatives, often spearheaded by international organizations in partnership with national governments and NGOs, offer insights into what works, what doesn't, and how approaches can be refined for greater impact. By examining the successes and limitations of these programs, public health stakeholders can better design interventions that are sustainable, inclusive, and contextually appropriate. One of the clearest lessons is the importance of local ownership. Programs that actively involve community members, local health workers, and grassroots organizations tend to see higher levels of acceptance and participation. For instance, the success of UNICEF-supported anemia reduction initiatives in Southeast Asia has been linked to the inclusion of community feedback mechanisms, allowing for adaptations based on cultural practices and real-world challenges. This localized approach helps tailor interventions to specific dietary habits, beliefs, and economic constraints. Another significant takeaway is the value of integrating anemia interventions with broader health and development agendas. Multinational programs that combine nutrition efforts with maternal health, education, and poverty alleviation strategies are generally more effective. The World Food Programme's initiatives in sub-Saharan Africa demonstrate that when food supplementation is paired with school feeding programs and agricultural support, the impact on anemia rates is more profound and enduring. Sustainability is also a recurring theme. Programs that rely heavily on external funding and short-term goals often struggle to maintain progress once the initial phase ends. Successful models, such as those supported by the World Health Organization, emphasize capacity building, training local health personnel, establishing supply chains for fortified foods, and embedding anemia screening in routine healthcare. These efforts help ensure that gains are not lost when international partners reduce their involvement. Monitoring and evaluation have proven to be both essential and challenging. Some multinational programs have faltered due to weak data systems, making it difficult to measure outcomes or adjust strategies in real time. Lessons from global nutrition initiatives highlight the need for consistent tracking of anemia prevalence, adherence to supplementation protocols, and quality control in food fortification. When done well, monitoring allows for course corrections and accountability, ultimately improving effectiveness. Lastly, collaboration among international agencies, governments, and civil society is crucial. Programs that foster multi-sectoral coordination and share best practices across borders have demonstrated a higher likelihood of success. By learning from these multinational efforts, future initiatives can be more agile, targeted, and resilient in the ongoing fight against nutritional anemia. Voices from the field, healthcare workers and beneficiaries. In the effort to combat nutritional anemia, the perspectives of healthcare workers and beneficiaries provide powerful insights into the ground realities of intervention programs. Their voices reveal not only the human impact of the condition, but also the successes and shortcomings of public health efforts aimed at its mitigation. These first-hand accounts add depth to our understanding and highlight the importance of empathy, cultural sensitivity, and adaptability in health interventions. Healthcare workers often serve as the first and sometimes only point of contact for individuals affected by anemia in resource-limited settings. In rural parts of Nepal, community health volunteers describe the emotional and physical toll on pregnant women suffering from anemia. They recount stories of mothers arriving at clinics visibly exhausted and short of breath, symptoms that could have been prevented with earlier intervention. These workers emphasize how education and consistent follow-up have made a difference, noting improvements in community awareness and compliance when women are counseled in local languages and visited at home. In Uganda, a midwife stationed in a government clinic shares her experiences managing antenatal care. She highlights the challenge of ensuring consistent iron supplement distribution due to stockouts and the lack of transportation in remote areas. Despite these hurdles, she finds satisfaction in witnessing the transformation of mothers who receive proper care. When a mother comes back stronger with a healthy baby, it reminds me why we do this work, she says. Equally important are the voices of the beneficiaries themselves. In India, a young woman from a low-income neighborhood speaks about the changes she experienced after participating in a government-run nutrition program. Initially unaware of anemia's symptoms, she was diagnosed during her second pregnancy. Through education sessions and iron-fortified food distributions, her health improved significantly. She now encourages other women in her community to attend health camps and seek regular checkups. Children, too, have been impacted. In Ethiopia, a school-based nutrition program introduced iron-rich snacks and provided deworming treatment. Teachers observed noticeable changes in students' concentration and energy levels, while parents expressed gratitude for the improvements in their children's academic performance and overall vitality. These voices underscore that while data and policies are essential, the lived experiences of individuals shape the true narrative of public health work. Listening to and learning from those on the front lines not only helps refine interventions, but also fosters trust and cooperation, essential components in the long-term success of anemia reduction efforts. Conclusion. Nutritional anemia remains one of the most pressing public health challenges in developing nations, affecting millions and impeding progress in health, education, and economic development. Its multifactorial nature, rooted in dietary deficiencies, socioeconomic disparities, gender inequality, infections, and systemic barriers, demands an equally multifaceted response. This book has examined the complexity of nutritional anemia, highlighting its causes, consequences, demographic patterns, and the socio-cultural and economic dimensions that shape its persistence across the Third World. Through this comprehensive analysis, it is clear that no single solution can address the burden of nutritional anemia. Effective strategies must be holistic, culturally sensitive, and grounded in the lived realities of the populations most at risk. Interventions such as food fortification, supplementation, community education, and the strengthening of healthcare systems are all critical components of a coordinated response. However, these measures can only be successful if they are designed in collaboration with communities, are supported by strong political will, and are sustained through adequate funding and infrastructure. One of the recurring themes throughout this analysis is the importance of community participation and the central role of frontline health workers. Their experiences and insights offer valuable guidance for tailoring interventions to meet local needs. Beneficiaries' voices also remind us that behind the statistics are individuals, mothers, children, teachers, and healthcare providers, whose well-being and futures depend on the quality and accessibility of nutrition and health services. Multinational programs and case studies have shown that change is possible when global expertise is paired with local engagement. Lessons learned from both successes and setbacks underscore the need for adaptability, continuous monitoring, and investment in sustainable solutions. Innovations in diagnostics and delivery systems hold promise, but must be integrated carefully to overcome challenges specific to low-resource settings. Ultimately, addressing nutritional anemia is not just about treating a condition, it is about advancing health equity, ensuring human dignity, and enabling communities to thrive. It calls for global solidarity and local action, informed by evidence, shaped by compassion, and driven by the belief that every individual has the right to a life free from the burden of preventable disease. As we move forward, a continued commitment to interdisciplinary collaboration and inclusive policy making will be essential to overcome this long-standing yet entirely solvable public health issue.